So now we'll start with CTO intervention session. Requesting chairpersons Dr. Baiju CK, Dr. Pratap Kumar N, Dr. Rajesh Shekhar Verma, and Dr. Rajivi to come forward to the dais.
Good afternoon. Thank you, ICCK, Dr. Ashish, Dr. Pratap, for having me here, despite a very late case entry. So this was an 80-year-old gentleman who presented with refractory angina and a positive treadmill test. Significant comorbidities in the presence of diabetes, post-COVID, post-excision of carcinoma tongue, post-bypass surgery 20 years ago. The angiogram showed native calcific triple vessel disease, patent lima to LAD, and occluded venous and other radial grafts. Viability and ischemia study were done with nuclear imaging. It showed a non-ischemic LAD, ischemic and viable LCX and diagonal territories, partly scarred and partly viable RCA territory. The plan was CTO PCI to LCX with LMCA bifurcation and D1 stenting after intravascular lithotripsy. So this was the procedure. This was the initial angiogram with the EBU guiding catheter 7 French through a right femoral artery approach. The left femoral axis was also taken. So the still image on the right side shows the complexity of the lesion. It's a distal left main calcific stenosis. You can see a very narrow distal entry into the LAD. You can see a small channel which fills the LCX. The LCX filling mostly happens retrograde via collaterals. So it was very impossible to have any sort of antegrade entry despite trying with hydrophilic filter FC wires, despite an attempt at reverse wiring to enter the retrograde channel. So that was abandoned soon enough, and we wired the diagonal. Even the smallest balloon could not cross across the left main proximal LAD stenosis into the diagonal. So that was finally crossed with a zero profile Icck 1 mm balloon that was upgraded to 1.25, 1.5, and then 2 mm balloon to create an entry into the diagonal. After which a microcatheter could cross, and with the filter FC wire, we reached the diagonal. Further angiogram, we can see that there is a good ipsilateral collateral from one of the branches. And this branch was selected. The fine cross microcatheter and filter FC wire could enter the branch. Further tracking of the epicardial collateral was done with a SUO03 wire with the fine cross microcatheter kept a little far away. And this SUO03 wire was successful in traversing across the ipsilateral collateral and reaching the end of the LCX CTO. So further entry could not happen into the LMCA or the LAD with the SUO03 wire. The microcatheter was tracked across, and the wire was changed to a Hornet 14 wire, which punctured the CTO and could enter antegradally into the LAD. It was not possible to track this into the LMCA. So this wire was changed to a filter FC. With great difficulty, the wire could be manipulated and could enter the LMCA and come out into the aorta. So a second guiding catheter was taken from the left femoral artery axis. The axis was already taken, and the guide wire was easily entered into the second guide, where it was trapped with a balloon. The microcatheter, the fine cross microcatheter, crossed the LCX, LMCA, and entered the second guiding catheter, where the wire was exchanged to an RG3, which was externalized. After that, antegrade wiring, after antegrade balloon dilatation of the LCX, LMCA LCX ostium was done, subsequent to which antegrade wiring of the LCX was done. An OM branch, early OM branch was also wired. serial balloon dilatations were done. This was followed by intravascular lithotripsy to the beginning of the diagonal LAD and the distal LMCA. The IVL balloon did not cross into LCX, and thus the only balloon dilatations with cutting balloon and scoring balloon were done to the LCX and diagonal branch. Subsequently, IVUS was done to get the vessel sizes. A DK crush stenting was done from with LCX and then LMCA to LAD. Initial kiss and again the final kissing balloon and pot was done. However, because of the very difficult entry, because of the difficult calcium, the distal perforation of the diagonal branch was seen. So that was wired again with a pro-grade microcatheter and a micro nester coil. The coiling was done. There was some effusion. So that was a reason for coiling the perforation. After that, the final results were good. This was the final result in the LMCA, LCX, and the diagonal. So hardware I have listed. So, in summary, a complex PCI in an elderly, frail gentleman with multiple comorbidities. Failed antegrade approach in a difficult entry L6 CTO was tackled with a retrograde approach via ipsilateral collateral. Effective calcium management was possible with intravascular lithotripsy. IVUS guidance enabled stent optimization. Despite precautions, complications do happen in complex PCI, and one must be geared to tackle it appropriately to prevent morbidity and mortality. Thank you very much.
Thank you, Dr. Verma. Yes, the last take-home message was very appropriate. In spite of precautions, complications do occur. Now, I just wondered, what was the Lima shoot show?
Yeah, the Lima was patent and was connected to the LAD.
Okay.
And that was patent. The LAD was showing good flow, so we didn't have to revascularize the LAD to LAD. The LAD further down, we didn't have to revascularize.
Okay.
We just opened it into the diagonal.
When you ask the Lima was patent, whether you have to do only stemming from the LMCA to circ or not, that is what is.
No, because of the stenosis, there was no proximal flow from the Lima.
Lima is patent, right?
Lima is patent, and it's filling the distal, mid and distal LAD, not covering coming to the proximal part of LAD, not filling the first diagonal, and the first diagonal is partly filled, but L6 was not filled.
So my question is actually, will you advise everybody, if you have a lesion beyond the first septal, if there is an occlusion in the LAD, will you advise everybody to do a stenting from LMCA to LAD?
No.
My question is very clear. LMCA, after LMCA, in the osteoproximal part, there is a lesion. There is a very good septal coming. After the septal, there is a complete blockage, which is, anyway, Lima cannot fill that. So will you advise for every patient to do a stenting from LMCA
No,
to
because
LAD to get the...
this was because the LMCA had to be opened to enable good flow into the LCX.
LMC is okay, but
Yes.
LAD part.
No, LAD part we're not
stent or
encroached
DK
much.
crush.
No, the LAD, the diagonal territory and the LCX territory were ischemic and viable as per the nuclear imaging, and that was ischemic. There was no flow into those areas.
This was a question I asked for every time with a lot of people, that whether we have to do such an intervention. My question is, that is a different thing. But for interventional point of view, why didn't you use a double Newman catheter to take a Hornet 14 to the circumflex ostium? Rather than taking an epicardial collateral to get an ipsilateral entry and creating a dissection in epicardial collateral will be dangerous, Why didn't you take a double Newman catheter, keeping the wire into that, and then take a Hornet 14 into the circumflex ostium?
The double,
You opened with the circumflex ostium with a Hornet 14 retrograde, right?
yes,
After taking the microcatheter. The same would have done by double Newman catheter, keeping the double Newman catheter to LAD and then enter to the circumflex.
even a single Newman microcatheter was not crossing that.
How do you take a guide?
After much balloon dilatation,
After much balloon dilatation,
Yes.
you could have done.
yes,
You are telling it is actually even no, because after opening the circost, LAD ostium only, you have taken a microcatheter down. That
yes,
means
but
that
the
is-
angle is so very difficult.
No, but
The LMCA to LCX angle was very difficult. It was almost a retrograde entry.
It is possible.
It is a reverse loop entry, sorry.
You can. It is possible, but the only thing is, in a retrograde intervention, especially when an epicardial collateral is taken, if it is actually, if you cannot seal it off, it will be dangerous, and it will be dangerous to the patient's life. That you know, me know. That is why. That is actually the thing I just wanted to emphasize. But I think, thank you, Verma. It is a wonderful case.
We'll move on to the next presentation, CTO crossing in subintiminal hematoma slash dissection. Dr. Praveen SP, please.
Good afternoon, chairpersons, friends, and colleagues. So, my case was a 52-year-old male who had an acute anterior MI. He presented late to a regional hospital. There, the angio report shows as a two-vessel disease of the LAD and RCA. Echo showed mild LV dysfunction, and their note says that they had attempted an RCA CTO. And when I called the doctor up there, they told they tried with multiple wires, couldn't cross, and so they didn't do the LAD also, and so they referred to higher center. This was the angiogram at the initial hospital. They didn't produce the CDs of the procedure as such. Only the angio is available. So there is an RCA CTO and LAD as a mid-tight lesion, and there is a collateralization from the left. Then the next day, the patient was taken up for again angio at our center. The RCA shows that CTO, and LAD shows a straightforward lesion. So being an anterior wall MI, I just did the LAD in that setting. I didn't want to meddle with the RCA because it was attempted there as per their report. Then I told the patient we can plan for the RCA later. So after 4 weeks, I called him up for a PCA to the RCA. This was the angiogram after 4 weeks showing the RCA lesion and LAD collateralizing the RCA. First, I tried with the software was not going. I tried with a Fielder XTA wire, and it was not crossing beyond the mid. Then I changed the wire. I took a CrossIt 300. The contralateral injection clearly shows that the distal part is out of the lumen. Took a Gaia second and tried with all the wires whatever were there in the shelf except Concus series because I was not daring enough to take a Concus. So that is the situation. So after 2 hours, around 400 to 500 ml of contrast, this is the picture of the RCA. So then I abandoned the procedure there. There was no other, I could come out without any other complication. So that was the situation. So I told the patient we can do again after a couple of weeks. He was willing to come again. And this was the angio I did after a gap of 6 weeks. So I thought whatever I had dissected and all would have healed, but rather it has become an ugly pouch of dissection with all the contrast. And that shows the RCA 2 views. So I again tried with a Fielder XTA only. There was a microcatheter also. And I could make some progress, but I was not really sure where the wire is going. So the contralateral injection gave some hope to me. I found the lateral view very helpful. If you can carefully look at the lateral views, the second lateral view, you can clearly see that the wire has distally gone into the branch there, the wire tip. So I'm pretty sure that I have somehow gone into the true lumen. I took a good contralateral injection that clearly shows that the distal wire is in the distal RC. Then I tried to cross the fine cross down. It was not going. The smallest balloon, 0.75 alveo balloon was tried. That was also not going. Then I took a Corsair. It was a O fine cross. I took a N Corsair Pro and I could drill that through. And that was the left one shows the fine cross not going, and that one was the micro going down, and I exchanged the wire, and after the dilatation, showing a big gap of dissection all the way from the proximal to the mid RC. Then I dilated with a tube balloon, and this is the picture after dilatation. There was no imaging done. Then tracking the stent was difficult. So I had to take a guide liner, and since I dissected and I really don't know where all I have dissected, I decided to stent the whole vessel. And I took 3 long metallic discs and stented all the way from the distal vessel to the proximal RCA. And that is the final angiographic result. And that shows the first one, the second one with the hematoma, and that is the final result. Thank you.
2-3 comments. One, actually, between the first procedure, somebody attempted this case and it came to you. What was the gap time between?
4 weeks. 4 weeks.
Ideally, when you have a second attempt for any case, minimum 6 weeks time to be given. Ideally, 6 weeks to 8 weeks is the best time to do, number one. Number two, this is actually the Americans now tell, this is called investment procedures. Actually, you tell attempted, I tell attempted or failed. We termed it is called failed or an attempted case. Americans tells it is called investment procedures. And this is actually a very interesting thing. Most of the investment procedures, when they come back, you may see a channel down. You dissect it and there will be a channel down, and through that channel you can enter inside. There is a paper going to be published in the next year by US Columbia University, and telling that this will be the way of doing. So even a rough operator can be successful by creating a channel dissection in the initial level. And it is not useful in a case of LAD, but in RCA, you can attempt and do these things. That is one way of doing. Probably when you do an IVUS here, you may be seeing a lot of this initial part, maybe a lot of subintimal space will be there. That is why your materials are not going. Corsair, which one? Corsair Pro, Corsair Pro XS?
Corsair Pro.
There is a new Corsair called Corsair Pro XS.
It was Corsair Pro only. Yeah.
Which is actually easy to track down and then take down. That is one way of doing. Otherwise, you can try a smaller balloon and dilate. I don't know which are the balloons you took. Icck 0 is a good balloon to take. And I usually take Icck 0 or a Nick Nano balloon or even a Ryuri 1.25. Actually, when you take the balloon, cannot go down. What you do is you keep the balloon in the proximal part and then keep the wire stronger and rotate. Rotate means you rotate and just push the balloon down. That then will be, balloon will behave like a tonus. A tonus is not available now. That is why these are the small techniques, but I should not tell these things.
I tried
now,
0.75 was the smallest balloon I tried.
0.75 that what balloon?
Alveo.
These
Icck
are
was
all-
also tried. We had Icck also.
These
One
are
was
all
tried.
Actually, if you try Alveo 0.75, take a 1.25 of Ryuri. I'm not supporting any company and I don't support Thermo as such. But even then I'm telling, the Ryuri balloon is better than these Alveo balloons, 0.75.
No, I showed Alveo, but I tried all the 1.25, all these balloons. After that only I tried 0.75. I
I'm
just
telling
showed
this-
that only in the slide.
These are the ways I'm just telling you, possibilities.
Praveen, 2 point, very nice case. First thing is, in fact, whenever you are in the subintimal space, in fact, did you try for a parallel wire taken into?
It was also tried. Yeah,
It was
I showed
also
that.
tried.
Yeah.
And the second thing, even after a repeat attempt, in fact, when you are going for the procedure, in fact, the support of the catheter was less, lower, right? In fact, even it was a JR.
It was a JR.
JR. Did you think of taking?
That's cathedral would have been there, but actually there is a small dissection in the osteoproximal part of RCA. But in those cases, better to take an anchor balloon and try the catheter rather than taking a ambulance catheter, because you will dissect too much into the RCA. But I will tell you that in the initial level, when you check the retrograde injection, your balloon wire has gone so far distally, you should not do that. You should check the retrograde injection much before in the mid part itself. Then you can you don't have to dissect through too much.
As far as the balloon is concerned, we should remember that it is not the diameter of the balloon expansion that is important, but rather the crossing profile. So even though it's a 0.75 balloon, the profile may be equal to a 1 mm balloon or a ray 1.25.
No, I tried a 1.25, 1 and then only 0.75. Just showed 0.75.
No, that's what I'm saying.
Yeah.
It is not the diameter
Correct,
that is
correct.
important.
Yeah, yeah.
It's the crossing profile that is important.
That is the same thing actually. I just wanted to tell you, some of the balloons of some of the companies, the profile is even 1.25 will be better than 1 or 0.75. That's what I just want. Maybe, but you can try like this. Rotate the balloon and then push. At the same time, when you take it back, you reverse rotate everything. Otherwise, the wire also will come out. I think if there is no more questions, we'll go to the next case.
thank
He
you.
is creating problem. 18 seconds left. Next case is by Jimmy.
Yeah. So thank you. Only thing is, CTO is something which is not an ad hoc procedure. It's a well-planned procedure, should be planned all the ways to do it. So I got a case like a 32 years old male with no comorbidities who had presented with angina at a local hospital in Middle East. And he was diagnosed to have inferior wall myocardial infarction and underwent an angiogram over there. Fortunately, he had a fair LV function. And this was his angiogram done over there, showing a left main mild plaquing with a proximal LAD ambiguous stump almost CTO across a small ramus. Proximal circumflex also has a borderline disease. And the cranial view also can see the entire LAD occluded. And RCA also has a subtotal occlusion, seems to be an acute inferior wall thrombotic occlusion now, but a well filling of LAD collaterals. So you got an ambiguous ostial CTO LAD, a proximal blocking in the circumflex, and a RCA subtotal occlusion. A bypass surgery option was given. Considering his age and all, he thought he would go back to his native place, come back to Kerala and take a second opinion. So we took a re-angio, which shows distal plaquing of the left main. Proximal circumflex also has got a hazy plaque. And ostial LAD is occluded, which is filling well from the retrograde collaterals from the right. And fortunately, this time the RCA has opened up. It was around 4 to 5 days after his primary event when he was discharged. So that has been opened up well with the antiplatelets and heparin, what was given over there in the regional hospital over there. So we also gave him the option of CABG. Considering the RCA open, we thought like if he's turned out with the option of CABG, then there is a possibility we need to stent this one before it gets for a reocclusion. So he was not quite keen for cabbage at that time, so RCA was stented without much difficulty. 2 long stents were deployed in the RCA, and that was the final result. And you can see the LAD filling well from the retrograde collaterals. This was followed by circumflex stenting, which also had quite hazy lesion, and that was the final result over there. At this moment, we had kept the LAD alone and still given him a choice of cabbage. At the same time, we had seen the collaterals had come up, filling the LAD. We had all sorts of CC0 to CC2 collaterals over there, which would become more as more time is given for this RCA to fill up. So again, an option of grafting to LAD was given, but he was keen on going with a CTO PCI. Thought we'll give some time for the collaterals to be more prominent and more secure if the antigrade procedure fails. So 4 weeks waiting period was given. After a limited antigrade attempt, which was in failure, thought of going for the retrograde attempt. So this was a Fielder XTAY, which was used for antigrade. Negotiated was not finding it difficult to negotiate the CC2 collaterals, which was there, but most of the time it was going outside. Hence, it was exchanged with a SO3 wire, which crossed the last of the collaterals towards the mid LAD. But unfortunately, you can see that the SO3 wire crossing and reaching the distal LAD. But the patient had a sudden jerky movement, and unfortunately, the guide pushed off, and entire system came out of it. Even though the microcatheter was there, the entire system came out of it. And that was the biggest failure because repeated attempt crossing these collaterals went in vain anyway. So it almost, you can see the multiple hematomas or multiple bleeding which is occurring across the collaterals because of the repeated attempts over there. So after almost more than 30 minutes of attempt, we thought it's time to reattempt an antigrade, this time with an IVUS guided because there was a good circumflex as well as the ramus available. So maybe an IVUS guided attempt could be possible out if at all. There's a lot of calcium also visible out there. So this was a Boston IVUS which showed the pull through from the circumflex was taken out. And you can see that there was a small early OM available out there in the IVUS, and followed with the ramus, which also could be visible. And just besides the ramus, some calcification spicule, and you can see the proximal. Hopefully, that could be the ostial LAD CTO, which could be punctured with an IVUS guided. So you can see the ramus wire over here. And just beside the ramus wire, you can have that ostial proximal cap of the LAD ambiguous stem, which was punctured with a Gaia 2 wire. You can see that Gaia 2 wire had entered in the cranial shoot, but seems to be in the subintima. The first shoot shows it's well outside the subintima, not in the true lumen, and hence a parallel wire technique with a pilot 200 was used because the entry was in the true lumen. So there's a pilot 200 crossing which was confirmed in the retrograde shoot to be in the true lumen. The second one, you can see the crossing the mid LAD. It was pre-dilated with multiple balloons and the guide plus extension catheter. 2548 and 348 stents were deployed. And a pot was done with a 4x8, and you can see the ostial circumflex being pinched. And you can see in the earlier IVUS also there was a blocking in the ostial circumflex. Hence it was recrossed, and a 3-5-15 deb and a kissing balloon dilatation was done. And an IVUS which also showed, I'll just be fast anyway, with this almost the mid LAD area of 7.9 and the proximal and LAD of 9.7 to 10.5, and the left main almost 12.6 areas there. And you can see in the IVUS also there is almost opening of the circumflex with no struts across it. So there was a final results. You can see in the borderline also where the struts are free in the proximal part, and the circumflex area also is quite good. And there was a final angiogram result. So it was an LM plus triple vessel disease with a double CTO. One was an acute occlusion. Multiple options of devascularization should be well discussed with the patient prior. Acute lesions always tackled first. Give enough time for the collaterals to be more clear, and if possible at time of retrograde crossing, that also option should be kept. Attempt retrograde most of the times in ambiguous terms if you don't have any imaging, but an IVUS guided proximal cap puncture is always sometimes helpful and handy. LM bifurcation imaging is quite a must, even in CTO cases, because you really need to respect the side branch vessel too. Thank you.
Jimmy, you took a wire, actually, Fielder XT. Which wire you have taken? Sugautri wire.
The first was a Fielder XTA, so
Then you took a-
then it was not crossing, so I exchanged with a SO3 wire.
Why did you take the microcatheter up that time? Your microcatheter was that time in...
No, the wire crossing to LAD was a SO3 wire. XTA did not reach the LAD.
No. Sugautri crossed into the LAD.
Yeah.
That time, why didn't you take the microcatheter up?
Yeah, when I was taking the microcatheter up, suddenly the patient had a movement and then the guide catheter came out. So the wire.
Usually, when you push the catheters wires up, you should have taken the microcatheter. Because there was an angulation, you have to take the microcatheter up that part. If you shift over the Sugautri that time with the wire, then your entry will be an easy. That is what I'm telling. You take a Sugautri wire. The Sugautri is actually very slippery wire. It will come out fast. So if you take the microcatheter also, there was an angle there, the septal angle, the septal perforator. You just go there. That part, that angle, if you take the microcatheter that time, I think you could have taken.
Yeah, the thing is, the angle of that PDA was quite difficult.
I know,
to
but that is what
you
you should have taken the microcatheter also up when you take the microcatheter. That when I take the wire there, I will also push the microcatheter up so that my entry will be easy. That is number one. Second is actually you have taken an IVUS in the later time and you could puncture. Why didn't you think about that in the initial phase?
It was kept in mind, but not done in the initial part because I thought retrograde collaterals were good.
Okay. That actually was, even in the first time I was telling that he told the patient to come back again for a retrograde intervention.
No,
Actually,
not retrograde, but attempt antigrade first.
C2 intervention later, but I would not have seen because I know that somebody will take caps of the patient. I would have done immediately that case.
Nice case.
Yeah.
Excellent demonstration of the IVUS guided proximal cap puncture.
Yeah.
And see, in CTO interventions, one technique is not always guaranteed to succeed. there are accidents that keep happening, and you have to switch between one technique to other technique. So in that way, it's a very good demonstration. Thank you, Jim.
Thank you, sir. Thank you.
We can go to the next case by Dr. Hari Krishna.
Good evening, everybody. I'm presenting a case of cardiac arrest precipitated by ischemia. The case scenario is a 46-year-old gentleman who had a cardiac arrest while he was climbing the Shabrimala, and he was resuscitated in one of the cardiac centers there. Somehow they could revive him, and he came back for evaluation. He is a diabetic, hypertensive, and he's also hypothyroid on treatment. Echo showed a viable LV with good LV function. Diffuse triple vessel disease, very high, prohibitively high Syndax score of 45, poor graftable distal vessels. We'll go to the angio. A lady had a CTO. The CABG was deferred by the surgical team, high JCTO score. So the angio goes like this. Relatively diminutive circumflex territory and no antegrade flowing of the LAD, diffusely diseased distal RCA, faint filling of the distal LAD. So one or two people had already seen, one or two surgeons had already seen. He's only 46 years. So anyway, it was not much difficult to convince this case for an intervention. Attempted with a CrossFit 100 with a microcatheter support. It didn't cross. Then escalated to Gaia 2. It slightly went ahead, and finally I could cross the CTO segment with a Congress port 12. I was not sure because it's in the true lumen or not, but overall tactile feedback was that I'm going in the lumen. So went a bit distal and took a microcatheter injection, removed the wire, took a microcatheter injection, which opacified the distal lumen, and I could ensure that I'm in the lumen. Multiple balloon dilatations, there was no much calcium. Multiple balloon, it was fibrous more or less, serially increasing balloon sizes, 1.252 at high pressures. Then stenting was done, distal LAD, followed by mid LAD, followed by LMCA to LAD. You can see the pictures here, post-dilated with appropriate balloon sizes. And final result was gratifying. Then again, you can note the severely diseased distal LAD, which is anyway, it's not graftable. Since there could be undersizing in such an underfilled vessel, and optimization was also done. And initially, you can see the stents, unexpanded, and the lumen area is also, the MSA is also less, 4.2 and 5.3 in the LMC and the LAD, which later improved to 8.7 and 8.1. So I consider it as a good result. So take home in this case would be a CTOplasty with a JCTO score 4 with deferred surgical option. The successful plasty, after being done as a successful plasty, facilitated a solution for preventing life-endangering arrhythmias and ischemia. IVS optimization was a good decision to add on to the better long-term outcomes. He's still on follow-up, doing well. Thank you.
Thank you, Dr. Hari Krishna. Very severe disease for a 46-year-old. Just one.
Go back to the first angio shot. First angio shot, for the academic interest. Okay. Just show that. The third slide. Okay, just keep the slide open. That's it. Okay, discuss.
No, I just want to ask you, see, you have used a 3 mm stent in left main, right? Yeah. Was it see, because when you have a severe diffuse disease, you tend to underestimate the vessel diameter. So by IVUS, what was the left main dimensions you could see?
I have not done a pre-run IVUS because there was even I had even in my dreams I didn't think that I would be completing this case successfully. So it was like kind of when I got it, I got it.
In
That's all.
dreams, if you are thinking that you will not complete the case, don't do the case. That is actually not. Actually, even in a very tough case, when the patient is dying also, in 10% of the time, we may think we may be successful 10%. Don't think that you
Yeah,
have a dream.
I had a high suspicion of.
No. You actually did a case in such a way that you may be successful. There is a chance of success. That is what I'm telling. My question is actually, just look at this angiogram. If you look at this angiogram, actually, if I do this case and everybody is rejected and I just wanted to do this case, if I do, I will actually try to open the PLV first. That means I just open the PLV and keep the vessel open because a lady, actually, if I cannot do and that distal vessel, I'm not very visible, and then I will try to open the PLV first, number one. Number two, when you pass the wire of Concus Pro 12, why don't you take a retrograde injection to understand properly that whether you are in the true lumen? I still feel that your wire is in distally in the subintimal space in the LED. That is what is my thinking. And if you had a running of the IVUS, probably you will understand that you would have stented some of the subintimal space also. That is what is my thinking. But I would have done in this case, I will this type of cases, if everybody rejects, you just revascularize one vessel. Then you can call the patient and do revascularize the other vessel. Then repeated revascularization will be better than doing in just opening up the LED, because RCA is easily can be done, especially the PDA part, PLV part. That is a very large territory supplying. This is what is my thinking. If you wanted to open a short stent and then you can do a regulating balloon into the larger PLV part, and that you can do, then you can call the patient again, because anyway everybody is rejected. You will get the patient back, because I'm very sure that this type of patient we can definitely try these type of things. This is what is my thinking.
Thank you.
Any comments from audience?
No, Harikrishnan, you have done a wonderful job. You have created a good LADC. Look, finally, there are no diagrams and there are no septals. And the terminal LAD is so small. So we are not sure about the long-term outcome. You feel very comfortable because you have done a good job. Technically, you have done a good job. We all appreciate that. But looking from a different perspective, that RCA, as Dr. Prathapan pointed out, there are some vessels which could have been tackled and all that. Whether it will
No,
translate
sir,
into
actually
something
after
very
doing
good.
the RCA, then LED is
I'm not too sure
LED
whether
will be
that
very easy to do also.
because there's nothing, the stented part looks good, but beyond that, there's nothing.
No, Hari, actually, if you do like this, actually you can do the LED will be much better because the collateral will open up very well. Then you're easy to see everything down and see. That is what I was telling. That should be the way of doing these type of cases. Diffuse vessel disease, and whichever the vessel can be vascularized and get the best result, you do that. Then you call the patient again after 6 weeks or 8 weeks. You'll be seeing, like you have seen that one case shown by Praveen SV. It was actually next time it will be doing better. And Jimmy's case, again, after 4 weeks, the collaterals have become much bigger.
One comment is about the microcatheter injection to know whether you are in a true lumen. That is something that should probably never be done unless you are planning to do a Carlino. That Carlino technique is the only place where you do a microcatheter injection.
Understanding the distal vessel is basically when you cannot enter that, you create and put the wire in a subintimal space and then put an injection, create a subintimal dissection distally, and then re-enter to the true lumen. It is not like that. What he just checked it, I just wanted to understand that I am in the true lumen or not. Earlier time, before the microcatheter come, what we do is OTW balloon taken, and then I shown the case, the first case which I've done. And those times, there was no way out. You have to check your distal vessel. Injection, if it is in the not in the true lumen, you are dissecting distally.
Better way is to inject retrograde and identify that you are in the true lumen, or you can pass a de-escalate the wire into a routine floppy wire and try to enter branches antigradely. That way also you know that you are in the true lumen. And
Thank you, sir. That is what revival studies. Revival tells that only bypass can do that. Intervention also can do that. Call for the next speaker, Dr. Sundar. So revival telling that only surgery is the best choice. No medical management is good. Or medical or surgery, no.
Good afternoon, one and all present here. So I am here to present a case of, it is not visible. Excuse me. Yeah. So I'm here to present a case of IVUS guided hybrid approach CTO PCI. So this is about a 53-year-old gentleman who is a known hypertensive, had inferior valve myocardial infarction in 2015, which was thrombolized with streptokinase. Presently, he came to us with unstable angina. The ECG showed sinus rhythm with Q waves in the inferior leads. Echo was showing mild LV dysfunction with hypokinesia of the inferior wall. So we proceeded with the coronary angiogram. Angiogram was showing a single vessel disease, which was a RCA, chronic total occlusion. And we can see the filling of RPD and PLB from the left injection. So the proximal cap was ambiguous, and it was a pretty long segment CTO, more than 20 millimeter, which comes to JCTO score 3. And we can see one septal interventional collateral which connects LAD to RPDA. So our plan was to go ahead with the initial retrograde approach. Why so? Because this patient had an ambiguous proximal cap, long segment CTO, and there was one septal interventional collateral to RPDA, which was CC1. So this is the septal collateral I told. It connects from the mid LAD to the right PDA. So we took a guiding cath of sound French EBU 3.5, and the septal crossing was attempted with the Scion Black and Caravel microcatheter, and we started doing the septal surfing. We took the retrograde wire and the microcatheter near to the distal cap and took a retrograde injection to confirm our wire position. And then we proceeded with the retrograde wire escalation. We attempted with all the wires which is shown in the slide, but none of them could cross the CTO segment. So what is the next step? We were unable to penetrate beyond the mid RCA. So at this point, we decided to go ahead with the antegrade route. And as you can see, the proximal cap is ambiguous. So we decided to do IVUS guided proximal cap puncture. We can see on a proximal side branch. So we took IVUS catheter to this side branch and kept a wire near to the proximal cap for puncturing. So this is the IVUS. We pulled back from the mid to proximal part of the side branch. As we pulled back, you can see this video here. So as we pulled back, you can see the RCA and the wire kept for puncturing in the true lumen. So using that, we can see at that around a 10 to 11 o'clock position. So using that as a marker, we punctured the proximal cap, and then we attempted, the proximal cap was tried to puncture initially with the Gaia third. We were unsuccessful. And with the Concourse Pro 12, we were able to successfully puncture the proximal cap. And then to increase the guide support, we use this anchor balloon in the side branch. And then using the retrograde wire as a marker, we tried to do antegrade wire escalation, but we failed to cross the CTO segment. So how do we proceed now? The retrograde approach failed to cross the CTO. IVUS guided proximal cap puncture was successful, but failed to cross the mid RCA CTO via the antegrade approach. So we decided to go ahead with reverse cart technique. So as you can see here, the balloon dilatation was done using the antegrade wire, and then reverse cart was attempted. The retrograde wire and microcatheter was taken into the antegrade guide, and then it was externalized with the RG3 wire. So now we were not sure about the subintimal space we have created, so we did not give any antegrade injection. So we took IVUS through the RG3 wire, and distally the RCA was in the true lumen. Here you can see the pullback from the mid to proximal RCA. In the mid RCA, we can see the IVUS catheter in the false lumen. As we come to the proximal RCA, you can see two wires here, one the side branch wire, one in the proximal RCA. So the wire has entered from true lumen to false lumen and again to the true lumen near the distal cap. So after taking the measurements, so here you can see the longitudinal, sorry. Here you can see the longitudinal view showing entire proximal to mid RCA in the subintimal sphere. So after taking the measurements, we stented the RCA with the 3 drug-eluting stents. Proximal was 3.5, mid was 3.5, and distal RCA to RPDA with the 2.75 millimeter stent. And this is the post-stent IVUS imaging showing the distal stent in the true lumen and the proximal to mid stent in the false lumen. So the IVUS post-stent analysis showed adequate stent expansion throughout. And this is the final angio, which shows preserved RPD and PLB. Some RV branches were occluded. And we did a retrograde injection with a microcatheter in the collateral, which shows no collateral damage done. So the take-home points are, imaging is invaluable in identifying the location of ambiguous proximal cap in CTO in the presence of a side branch. Imaging helps in understanding the wire position, true lumen versus subintimal, and subsequent stent placement in long segment CTO. Switching the approach, antegrade versus retrograde versus hybrid, in difficult lesions promptly saves time, decreases radiation, and increases the chance of procedural success. Thank you.
Thank you, Dr. Sundaram, for a very good learning case. I think this would be a very ideal case for an IVUS guided puncturing because you have an ambiguous cap, a side branch coming. Yeah. I think I think can enlighten us how to start IVUS guided puncture.
Can you show the?
Yeah, I can show that.
Can you just go back?
That's a very ideal case, I think.
Can you just open?
No. Let him show the case. Actually, the slide 5, 6, 7, 7th slide. Come down, come down, come down. I was trying to puncture. Come. Come. Okay. Just that part. Sundaram, can you explain that? Next. No. Go. Next.
I'll do that. Yeah.
Yes.
I was okay.
So,
just go.
sorry.
Go slowly.
So here actually we have to keep the wire for puncturing the proximal cap, and then we have to start pull back from IVUS from the side branch from mid to proximal. And as we pull back, we have to see when we come to the proximal RCA.
One important thing is you have to keep, it's only manual pullback. You should not take only manual pullback and keep that. Wherever you see the ostium of the RCA, then you keep there and then take the wire. And wire should be a wire like XTR, XTA will not do anything. And only a puncturing wire should be taken. A tough wire. We discuss now. You can.
And now we have to see, the position of the puncturing wire here. So if it is close to the EEL of the side branch, it means that the wire is likely subintimal. Suppose if the wire kept for puncturing the proximal cap is farther away from the EEL of the side branch, it means that the wire is likely intimal. So in that way, we can understand whether the puncturing. Here, actually, I'm unable to freeze this video. 1 minute. Yes, I will. Yeah.
First, just take from the initial. Okay.
So this is from the mid of the side branch. We are pulling back manually to the proximal part of the side branch. So now we are pulling back.
Stop.
Here actually we can see.
That is the part of the, you can see that actually that angle, that is a proximal part.
Around 10 to 11 o'clock you have to concentrate. So, sorry, just a minute. So you have to concentrate around 10 to 11 o'clock. Here you can see.
Actually,
this is the wire
Madhu, that is the only area where you can see a lumen chance. The other part is totally non-lumen. Actually, that is the place you have to puncture.
Once we pull back, we get a larger lumen, which means that we have come to the near to the proximal cap.
Yes, sir,
we are visualizing the RCA.
Now we see that wire in the 10 to 11 o'clock position.
Yes.
Now how to direct the wire from this position?
No, we have kept at a particular position for puncturing the proximal cap.
Into the RCA only. So that place actually, once the wire is crossed, you can understand.
So we have to check whether we have kept at the exact area for puncturing. Yeah.
Okay. Now, IVUS catheter is separate. Just
IVUS catheter is
take
separate.
a wire because there are two ways of taking. You can actually take a microcatheter and take the wire, but this 7 French catheter and all with IVs with the microcatheter will be little difficult, but you can take it.
Okay, so here you got the wire, that bright spot is the one that you use for puncturing.
Correct.
And how do you target it towards that?
No, initially that
You're fluoro and IVs together, Basically, you have to target and then puncture it. Once you puncture that, then rest everything. Only the proximal part only you can identify whether you are in the vessel or not. Rest everything is from the retrograde injection, nothing else. And that is why after puncturing, you may be in the subintimal space for a long distance. That is the only disadvantage. Only the proximal cap puncture is possible with that. Advantage is actually if you come retrograde, you are having a subintimal space. Otherwise, when you come back, the wire will be out of the vessel. It will be, I had taken once, the retrograde wire came, it came outside. I could have even taken snaring the wire out, but that wire was actually out of the vessel. Then I stopped the procedure.
So when you're pulling back, the wire is seen in the proximal RCA. The wire that you're seeing in the proximal RCA. What is your direction for that proximal wire to
See, actually,
where is the cap actually? Can you demonstrate the cap where
here
you're going to
we have
that is the cap.
But you're seeing the wire there. You're seeing the wire in the proximal RCA there. That bright
No,
spot.
wire is actually we kept there. We kept wire almost at the direction of that place. We were thinking that is the direction and just
Already the wire is in the proximal.
wire is actually kept in the proximal part. We are actually trying to puncture that part only. We already assume that that is a place.
suppose if the position is wrong, we will see that part close to the EEL of the side branch. The wire will be somewhere close to here, the side branch. If the wire is in the luminal position, or if it is intimal, it will be farther away from the side branch because the part we are visualizing is the side branch.
Madhu, major problem is actually very, very short osteoproximal part. That is actually, if you have a long space, then you can actually identify whatever you are telling. This is actually with the fluoro, with understanding, with imaging, and then trying to do that. Because otherwise, if it's good space means you can see all these things. Just go ahead. Go ahead.
Here the problem is we are not able to see the main RCA properly. We are just seeing the wire. You are pulling back from the side branch and you're seeing just the wire and nobody understands that where exactly you need to go, where exactly is the real RCA there.
Now we are
It's
coming
almost
back to the
up.
RCA. Now we
Yeah.
are coming back to the
This is in the RCA.
See, this is RCA. Now this is RCA.
Normally, when we pull back like this from the side branch, we clearly see the ostium of the side branch, the main vessel wherein you will have
Actually,
to puncture.
no. You just look
Here
at
in
this.
this image,
This
it's
is
not
now-
seen.
This is now right coronary artery.
Yeah.
Correct.
Yeah,
So whatever you are seeing on the 9 to 11 angle is the
wire.
point. So we actually kept the wire and withdraw and this manual rotation and pulling back and all. Just look at and just puncture. Once you puncture, you are entering the vessel.
True,
But
sir. I do understand that. But then the difficulty here is we are not seeing the RCA as such. This is the proximal RCA.
This
You have- yeah, this is a proximal.
there is only 2 millimeters RCA here.
But then the point where it divides into two. This has come out from a side branch, and the other vessel, normally you see in the IVS that you see a small
But
loop.
actually, I'm just telling, if the wire is actually sitting in the 4 to 5 angle, you can 100% tell that you are not in the vessel.
See, if you
See,
have
this-
a better
look, for
example
example-
for this, you need to show it over here.
But this case,
For people to understand, because I have an example sometime later I can show.
okay. But this case actually, this is what we have seen. It's a very, very short RCA, so we cannot do more than this.
Thank you, Dr. Santar. Very nice case and a very good discussion. I think that is the spirit of ICCK. Very good. Anyway, we'll go to the next case. Ostial flush occlusion of a lady, Dr. Ramesh Natarajan. Please, doctor.
Respected chairpersons and dear friends, my patient is a 48-year-old male, hypertensive. He had presented to us 1 year back with an acute coronary event, rest angina, and he had a double vessel disease. Right coronary was the culprit, so that PCI was done, and subsequently the LAD was a CTO flush occlusion that was attempted. So this was the picture, initially the right coronary stenosis and the flush occlusion of the LAD. And So the right was done at that time with a short amplifier guide and a filter FC wire, and the calculation was done. So you could see the collaterals filling the LED. And then subsequently, we did the anti-grade attempt at that time after a week or so with a dual injection initially, showing a long segment CTO with a JCTO score of 3. Initially tried with a filter XT wire, which entered the micro channel, and it was subsequently changed to a Gaia second. But then distally, the wire was clearly in the subintimal space. So multiple attempts were made at that time to direct it into the lumen, and after a fair amount of attempt, that procedure was abandoned at that time. And so subsequently he was lost to follow-up, and later on he presented near about 3 to 4 months, again with chest discomfort. So this was the angiogram during this admission. So in fact, he was initially planned for a retrograde attempt at that time, but he did not come for follow-up. So this time we thought here, this angio shows a moderate lesion in the circumflex, and again, patent right coronary with good collaterals. So we planned for a retrograde attempt this time. So the dual injection, we took bifemoral access, 7 French sheets, EBU and JR guides. And we tried with the, so you can see the collaterals from the PD to the LED. So we tried with the Corsair Pro, then initially filter XTR, and then the SO3 crossed. And you can see that there is a subsequent microcatheter injection, in fact, revealed that there was a diagonal there at the distal end of the CTO segment, and the wire was entering that diagonal. So antigrade also we tried with the fine cross catheter with a Gaia second wire. And subsequently, it was difficult to manipulate the retrograde wire into the CTO segment, but at that time we changed over the antigrade wire to the Gaia third, which in fact advanced. And the retrograde wire in fact served as a marker. So, and we could get this kissing wire position in 2 orthogonal views. And so just a slight push on the antigrade wire. In fact, the wire entered the retrograde microcatheter. So the retrograde wire was slowly withdrawn, and the antigrade wire could be directed. The Gaia third could be directed to the distal vessel, and this was confirmed by the RCA injection. And subsequently, the antigrade ballooning was done, serial dilatations. We required an anchor balloon for crossing with a 0.75 mm balloon, antigrade, subsequently serially dilated, and then stented with the 2 long stents. And this was the final result we got. So compared with the previous attempt, in fact, you can make out that the retrograde wire, in fact, helped in knowing exactly the location of the distal vessel. And probably this time we dissected a short segment because we lost the diagonal in this attempt. If you can see here, the diagonal into which the wire was going, that disappeared. But this time it was a short subintimal passage of the antigrade wire compared to what it was in the last time when it was a longer subintimal passage. So take home is retrograde wire crossing, reverse cut, and kissing wire position. They are all techniques that will help in the successful recanalization of CTO, and switching from one to the other may be required. And retrograde wire in this case served as a landmark for the antigrade wire escalation. Thank you.
See, actually, I have a comment. Basically, this type of retrograde CTO attempt will never be successful because your entry of the CTO, that is septal collateral, is at the CTO. You should have minimum 5 millimeter space to manipulate the wire. That's the point. If you don't have that space, in the initial attempt itself, you should try another septal collateral distal to that. Otherwise, you are entering into the CTO. So your manipulation of wire definitely will not go there. Either it will go down to the LED or to a diagonal. It will never go back because there is a CTO there. So that is why people are telling there is segment of a normal segment should be there between the entry of the septal collateral to the CTO segment of minimum 5 millimeters. That should be the point you can enter. That your entry will be easy to go and do the case. And that is the
There was,
primary thing.
I think there was significant distance between
There is
the
no space.
entry,
Just go
but
back.
it was,
No, no,
it
there
was,
is no space.
yeah.
Can you show the angiogram? Then we will see the angiogram again. No. Just go to the first angiogram.
I'm sorry.
Actually, Ashish is angry. But one second. Just show the angiogram. And,
Yeah.
can you show the angiogram? Whereas CTO is, no,
sorry.
CTO is starting, is ending there. Just, can you just, okay.
Yeah.
Start.
Yeah, this was the, there was sufficient distance. No, this was the septal.
Then why it is not going up?
No, it was that terminal portion, the distal segment of the CTO that was very narrow and it was ending in a, it was going directly into a diagonal branch. So it was like a antegrade CTO with a side branch.
No, that is what I'm telling. Your diagonal entry point from there, you are not manipulating. Why?
No, it entered that, and by that time my antegrade wire had come there. So I could have tried with a Gaia second or a more stiffer wire, and it might have crossed. So, but I got this position, and so the antegrade wire with the Gaia third, it reached almost till the distal cap. So because I got this position,
No, then we have to manipulate the wire from there and enter to the proximal entry. I don't know why it is not entered then.
Yeah. No, this was the wire position I got, and then subsequently the antegrade wire progressed.
No, your wire entry is at that junction. That is what I'm telling. Just see the junction where the diagonal starts, not distally. If your wire entry was away from that, away from the diagonal, you can manipulate. That is the same thing I'm telling. Your wire entry is at the junction of the diagonal with LED. That
No,
is
it was
why you could
it's
not
beyond
manipulate.
that. It's much beyond that.
But much above. Actually, that is what I'm telling, sir. So look at.
Yeah. Yeah.
Not very close. No, you
So
are
the septal
actually
is
entering
joining
a
here.
different-
The septal is joining well away from the diagonal.
But
In
your
the first picture, you can see.
Your entry is a different place.
No, it's in the other, only in the PA cranial it was appearing a little shorter, but the RA cranial shows that sufficient distance from the, sufficient.
Your diagonal is above.
Yeah, way above. Yeah. It's almost at the.
That means the entry of the septal collaterals, they are not here, I'm confused. No, sir, actually, I think you.
There's a good distance from the, see the septal.
Now you are telling the wire and the microcatheter is sitting in the LED.
So this
Wire
collateral,
retrograde?
this collateral is, the wire has taken this collateral.
Correct. Next. Now this
Yeah,
wire
so
is
this
in the LED or in the septal. That is a microcatheter.
Yeah, it's clearly shown here, see. The
Oh,
diagonal.
that is in the LED.
Yeah, the
Then why
middle-
don't you take a
the middle
manipulate?
picture.
Oh, now your wire is in the LED, proximal.
Yeah.
Then why don't you take a wire which can be torqueable? What is the wire here?
Yeah, this was a filter XTR.
XTR. That's what I'm telling
yeah.
you. You told fine cross with a Gaia second antegrade.
No,
And
that
the
is
Gaia-
antegrade, yeah.
Gaia second wire would have been.
Yeah,
XTR cannot take like this. That's what I'm
So
telling
that was the
Either
plan.
you should take a Gaia second wire. Let me tell. Either you take a Gaia second wire, which is a torqueable wire. You should require a torqueable wire. This XTR is not a torqueable wire to take inside. That's what I'm telling. I just wanted to tell you. Thank you, Ramesh. Wonderful case. We'll go to the next case by Ram Naresh.
Good afternoon to everyone. Coming to the clinical details, he is a 50-year-old gentleman, comorbidities of smoking, dyslipidemia, and hypertension, with a history of exertional angina class 2 to 3 symptoms, and echo was normal. He underwent TMT positive and he underwent angiogram, which revealed two-vessel disease, and he was attempted PCI to LAD, but stenting was not done in peripheral center, and he was managed medically. Then again he developed symptoms, exertional angina 2 to 3 months, and CAG was done in another center, which was showing hostile LAD, 100% flush occlusion, and there attempted PCI to LAD. It was not successful, hence advised CABG. This was the, then they came for the further evaluation. So this was the left coronary artery angiogram, which showed LAD ostial flush occlusion, and LCX, there is no significant stenosis. Left coronary angiogram was, we used 7 French XB3 guide catheter, and for RCA we used AL1 6 French guide catheter, and we take simultaneous injection for left and right symptoms, left and right systems. We can see the collaterals, well, septal and as well as epicardial collaterals. So CC1 for septal and CC2 epicardial collaterals. So what is the approach? The next step is either antegrade or retrograde, because we plan to do retrograde because of it was already attempted in another center antegrade, and there is already ostial flush occlusion and interventional collaterals, septal collaterals. So first we do IVAS run from LCX and to see the LAD anatomy and calcium and osteal to know the LAD osteal anatomy. And we took the Corsair microcatheter through cyan blue guide wire, and we entered up to PDA. After PDA, we taken out the cyan blue guide wire, and we check the proper septal collaterals, and we used the surfing technique to cross the LAD. Then Corsair was exchanged with 150 centimeters fine cross catheter for length and was advanced to the distal tip. Because of, I told before already, there is in the distal tip, there is already diagonal branch was there. So we directly used the Conquest Pro 12 wire for piercing the distal tip of LED. This was the, then after piercing the distal tip, we used the, we downgrade the guide wire, cyan blue, and we confirm the cyan blue guide wire enter the LMCA by pullback, I was pullback from LCX. This was the retrograde wire, and I was confirmation. So after that, we externalized wire and retrograde wire. We used Rendua technique, that is antegrade from XB. We used the Corsair microcatheter and run-through guide wire. And this was in the XB guide catheter only. We retrograde fine cross microcatheter. We enter the run-through guide wire. After that, we taken out the, in the second scene, we can see the, we are taken out the fine cross microcatheter and cyan blue guide wire. In the third image, then we see we are parking the LED wire. After that, crossing the LED wire, then we are seeing the flow limiting in the diagonal branch. So we are sequentially dilated the LED 2 into 10 and 2.5 into 15 NC balloons at 18 atmosphere. And we are using the dilate the diagonal also. So we are using the LM to LED stent 3.5 into 28 des at 12 atmosphere. And after that, LMC part, we are using 4 into 6 mm NC balloon at 14 atmosphere. After that, at this situation, patient was hemodynamically unstable, bradycardia and hypotension. Then we find out there is a ostial LCX thrombotic occlusion. So immediately we try to wire with flappy, but we couldn't cross. So we used the filter XT. So we crossed the L6 wire and we used the balloon. This was after crossing, and after dilatation, we'll get the L6 flow established and patient hemodynamically stable. This was the LAD post dilatation with 3 into 15 NC, 3 and 3.5 into 3.58 NC balloons, and kissing balloon dilatation for the diagonal also we done with 3 into 15 and 2 into 10 semi-compliant balloons, and final kissing balloon dilatation also we done with the LM and LCX 3 into 15 and 2.75 into 10. final LMC port was done at a 60 atmosphere of 4 into 6 mm NC balloon, and we took final IVAS run for post standing. And this was the MSA for LED and LMCA. LED mean 8 mm we achieved, and LMCA 12 we achieved. So this was the final result of.
Actually, don't stop it. Can you just go back to rendezvous? Can you show the rendezvous for demonstration? Okay, sure. Can you show the two microcatheter where it is sitting? That's what I just wanted.
So this
Actually, rendezvous means you should have two microcatheter together. From one microcatheter, the wire entered to the other microcatheter. That's what I just wanted to see.
It's in the guiding catheter.
Guiding catheter.
It's in the guiding catheter.
Can I see? That's why.
Yeah. So you can see the cyan blue, which was the de-escalated wire, which
I
is
saw
retrograde.
Shafiq.
Yeah.
No, I just wanted to see the two microcatheter together in the guide. Can you just stop and show
Yeah,
us? Oh, that part. That means. Okay.
Exactly. That's the portion.
So can you? The entry is not documented, right?
Must be there.
Second slide is there.
No. Can you play the first
that
run,
is
please?
one.
Yeah, that's one. Yeah.
So I think everybody should understand that there are
Yeah.
two microcatheter together.
Yeah.
He is entering the antigrade wire from the retrograde microcatheter to the
Antigrade is the
antigrade
corsair,
microcatheter.
retrograde is fine cross, and I'm crossing with the wire through that in
So
the guiding catheter.
this actually, when you do
Saved
that, when you push the wire down, when you actually pushing the antigrade wire down to this retrograde microcatheter, then your retrograde wire should come down.
Yeah, that's
then
what.
only you can come down. That's actually just wanted to demonstrate. So this wire should come down. Once the wire coming down, your
Slowly pull the wire back.
microcatheter can be there. The wire only should come down. When the wire coming down, the antigrade wire should come to the retrograde microcatheter.
Yeah.
Then as it is coming down, you pull the retrograde microcatheter out. Then you will be reaching the distal part. Then you take the retrograde microcatheter, put the wire distally and finish it off. Correct. Just wanted to show. That's all. One question: why there is a thrombotic occlusion?
So after pot.
No. Why?
No,
there
it is
no,
just.
Shafiq cannot answer. He should answer the question. Then you should present it. Why there is a thrombotic occlusion? This is the most important thing. In retrograde intervention, you have a lot of materials inside the coronary. So you should always check the ACT to keep ACT beyond 350 seconds. This is what is told in every CTO interventional program. Attend NATE's IJCTO 2024.
That was subtherapeutic. That time it was just 220.
That is what I just want to tell. Attend IJCTO 2024 in Hyderabad, June first week. Thank you. Thank you.
Thanks.
We'll go to the next case. Last case by third eye by Praveen.
Respected chairpersons and dear friends, this case was done as a part of a CTO workshop which was done at our hospital, and Pratap sir was with us. So any questions may be directed to sir. We had a discussion about the proximal CTO cap penetration. Actually, that was done in this case. We also wanted to learn it, so this was done. It's a 32-year-old male who had presented with CAD and STEMI, risk factors of family history of CAD and smoking. CAG showed 2 vessel disease of middle LED CTO and a distal circ 80% disease. Elective plasty to LED CTO was attempted as a part of the workshop. There's 7F EBU catheter and a diagonal was wired with a D1 run-through wire, and a fielder XT wire was initially tried as an antigrade attempt. I think an earnest attempt we could have crossed with a CTO operator like sir, but we wanted to have a demonstration of the CTO cap penetration, so we asked sir's assistance for that. So this is the proximal CTO cap. The IVAS catheter was passed into the diagonal wire, and then as sir said previously, a manual pullback was done. The arrow clearly now shows that is the CTO cap that we have to target, and under IVAS guidance, the cap was penetrated with the Gaia 3 wire, Gaia 2nd wire, the same seen in this, and then the procedure was easy, just like the CTOs, wire positioned in distal LED, serially pre-dilated with 1.5 and 2.75 balloon. This pre-run showed a proximal and distal landing zone with a stent size of, we selected a size of 3 into 33 drug-eluting stent. Post-dilated with 3.5 in the proximal. And post-ending angio showed a minimal defect in the distal LED stent, then which we confirmed with the IVUS run. IVUS run again showed a hazy defect with a possible dissection in the distal stent edge. The arrow points to the dissection that was noted in the IVUS run. So we had a new provision of the OCT also as a part of the workshop we thought we'll demonstrate both. The OCT run also showed a dissection extending to a length of 4.8 millimeters from the distal edge of the stent, extending in the media. So we thought we'll cover that with another second stent. An overlapping stent of 2.75 into 8 mm was done. And this is the final angiogram. So I hope the discussion about the previous proximal cap penetration can be cleared from this slides. And this was a post and run which showed good areas that we achieved in both in the mid and the distal part of the stent. So the take home points would be IVUS guided CTO cap penetration is a very good option, especially in ambiguous terms. OCT and IVUS can be used complementarily in CTO cases. And forward looking IVUS technology like anti-owl, etc. is, I think, I don't know whether it is available, holds great promise in CTO cases. Thank you.
Sir, can you use this? Can you show this here, sir? This is more. Praveen, can you just go back and see?
Questions may be please directed to sir. I can show the run. I'll show them.
Actually, you call me for a case in your hospital. I will demonstrate, and then next time you bring the case. See, these are all I'm doing on the spot and telling, just puncture and finish. That's all. I don't remember because these should be captured. Most of the time it will not be
Sir, is
captured.
it seen in
Very difficult to
this
capture
run?
Previous slide.
One more run is there.
I think the slide previous to this.
This run shows that the LED wire is already into the. You see that.
Again, go back.
Yes,
Again,
sir.
go. Just go there. No.
This is the diagonal wire.
Diagonal wire.
Diagonal wire. And this is the CTO cap. If you closely observe, you can see the wire now coming up slowly in the. See, this is the LED wire. The wire which has passed into the cap. I will show it in the previous slide also.
Actually, we find out the cap. Then we puncture. There are two ways of doing. Keeping the catheter and then puncture, or find out the place and then come back and puncture and demonstrate you punctured the cap.
See, now this is the CTO cap.
That's the CTO cap. And keeping that, and that cap there, take the, it will be very difficult to manipulate the catheter and the wire together. So take the position and take and puncture. Puncture means not far away, 1 or 2 millimeters. Take the IVUS catheter again. Demonstrate that you are in the lumen. Then take out and finish. That is the best way of doing. There are two ways. Keep the catheter and keep two wires and the IVUS together, or find out the lumen and then puncture and then take the IVUS again to see that you punctured. That is the way it's done. See, that is a place you have to puncture. I think this much Ashish will kill us, and final comments from Daesh Parma and finish it off.
Thank you. It was a great presentation. Again, good demonstration of the proximal cap puncture. Again, one should remember that the IVUS guidance is only for the puncture of the proximal cap. Further progress of the wire can be intimal, subintimal, that we have to see in different angio profiles, not on IVUS.
No comments.
Yeah, thank you very much. We'll conclude the session here.
Thank you, Anandal. So next, we'll have a session on coronary potpourri. Requesting the chairpersons, Dr. Baijua, Dr. Krishna Kumar, Dr. Nanda Kumar, and Dr. Umeshan to come forward. Requesting the chairpersons to come forward to the dais and occupy the chairs, please.
think we go ahead with the first case by Dr. Ashokan.
So this is a simple, straightforward case. PCA in a calcific anomalous tortuous artery. There is a 60-year-old male and was present with unstable angina with good LV function, and CAG revealed three-vessel disease, anomalous origin of RCA with a calcified tortuous, severe tortuous RCA with proximal mid and distal stenosis. And this is a left angiogram. You can see that there is a 80% stenosis mid LAD. And this angiogram showed a very tortuous segment with the calcification in the proximal, mid, and distal segment. So, how do you approach this case? Most important thing is adequate guiding. You have to use a large guiding. And in this case, a selected Amblat's left. And active engagement, a limitation in this case. So, use deep engagement, tried by body wire, and selection of extension catheter, guiding extension catheter. So very important in this case, so that you can increase the passive guiding support. So how to wire this? You have to use mica catheter. Otherwise, you'll have a lot of difficulty in actually advancing the wire, which helps to wire handling. You can direct the tip, allows the changing of the guide wire. That's very important. And exchange of the guide wire. You can use any type of wires if you are using mica catheter, preferably non-polymer jacket wire. So we have the newer generation wires, and used in this case cyan blue. So this is the guiding support. You can see the L1. You can see this guiding GS. We use the guidezilla, 7 French guidezilla, and mica catheter. Advance the cyan blue, cross the CTA segment. You can see the severe calcified segment, the proximal mid. So there's one thing. And use the rota here, say 1.5 bar, with the help of guidezilla support, 7 French. So here, if you're using the rota, we have to avoid 6 French devices. So whether it's a guiding catheter or especially if you're using GES, because only 1.25 you'll be able to advance through the 6 French guiding extension catheters. So I tried OCT. I failed because I could reach only the proximal part. You can see the severe calcification with severe reduction luminal area. So I tried to advance the guide wire with the help of this rota wire and exchange with the help of a mica catheter, that is fine cross catheter. Then did initially the rotablation of the normal segment to the proximal initial tortuous part, then the distal portion, you can see that. And this we already discussed. And you can see that after rota, lot of lesions. This is what we call a pseudo lesion because of the straightening of the tortuosity. And you can see the mid and distal very tortuous segment. Now the job is to advance, we have to prepare the lesion with NC balloon, then advance the stents, because you have to use a very long stent with the help of a guidezilla. And inflated the distal portion, then the mid and proximal part with NC balloon. And you can see that this guidezilla, you are able to advance up to the mid portion of the RCA. This is a different technique, whether it's surfing or trapping the balloon, you can advance that. Did that, and we advance the guidezilla up to the mid portion, then push the long stent, we are able to advance the long stent, that's 3.5 into 48. We used here the synergy stent as a distal portion, and inflated that part, and then post stent did NC balloon dilatation. Then the mid and proximal portion, this is a 3.5 is a fire rock stent. Both are newer generation stents, and this is a final result. And this angiogram, you can see that you got a reasonably good result, and you got a 6 months follow-up of this patient. This is a follow-up angiogram, not this is a follow-up angiogram, and 6 months after the case.
Excellent.
So, what is the message? So, anomalous tortuous RCA though rare, if it comes with this severe tortuosity with the calcification, we had to use a multi-device technique with here guidicilla used, microcatheter, deep intubation, and adequate preparation lesion with the rota. And it's a rota in this case is off-label and not recommending, but if you are interested, you are experienced to do it, because you have to be careful here in this forum. So, and long stent delivery, it can possible only with guiding catheter support. So, multi-device approach in a severe tortuous with a calcified lesion, proximal dentition. Thank you.
Excellent case. Very, very difficult case. Very tortuous case. Just one thing. When you are doing a rota in such a tortuous vessels, which there could be wire bias, and what all precautions to be, test for what all
See,
extra precautions to be taken in rota in
one
doing
is
like tortuous.
you know that if you use this tortuous lesion, we should have adequate guiding support. So invariably you have to use guiding catheter support, extension catheter. And ideally, if you're using 6 French, only guidicilla will help, because the inner lumen is slightly larger than when compared with the telescope or guideliners by 0.001 inch higher. But if you're using 7 French, there's not much of difference. You can use any of the guiding catheter. That's one thing. Otherwise, you may produce some dissection, little bit of perforation you have to expect, and perforations, yeah, we have to expect, but you have to avoid, because one thing is lax of the wire, the proximal part may go to one side, may produce perforation. That's one thing.
Excellent case. Could an additional guide wire could have straightened out the vessel?
Yeah, but we have to use here rota ablation. Initially, I tried body wire here.
Choice
But
extra support
yeah,
wire or something?
yeah, but you have to use your rota wire, so I thought I'll do only this. 1.5 bar I used. Yeah, with the 7 French guiding catheter support. GEC, you can use 1.5. Otherwise, 1.25 only. If you're using 6 French, 1.5 guidicilla. No other catheter will help. Yeah, you can use multi-purpose catheter as a guiding. Yeah, that also gives support. But it will indicate a deep intubation, the catheter is one thing. Anyway, it use another device like say extension catheter. Otherwise, you won't be able to do this, because especially calcified dish.
Sir, you wanted it more difficult. That's why you used a 48 millimeter stent.
Because there are two, it's a very important question. In a tortuous lesion, anyway, the perfusion pressure is distally less. If you have, otherwise also, if there is no lesion also. But here there is a significant fixed atherosclerotic lesion, it's around 80% stenosis in the distal portion after the third tortuous segment with angulated. So I had to use, because another lesion in the mid part, instead of using 2 stents, and with a little bit of, without overlapping area, I thought we'd use 1 stent and finish up. And if you see the follow-up of these cases, you'll have say 2.7 versus 1.3% higher chance of target vessel occlusion. That is there. That it. But the third generation, we don't have any studies in the tortoise vessel, third generation stents.
So when you're tracking inside a guide extension, the rota, you'd go it with a Dynaglide mode, or you?
Yeah. I think you are presented in NIC. So we did here with without that. So manually I did. Ideally, you have to go with that.
Thank you, Dr. Ashok. An excellent case. We'll invite Dr. Balakrishnan for the next presentation. Jain coronary artery aneurysm.
Good afternoon, chairpersons, dear friends. When Ashokan said it's a simple case, I thought, okay, let me come out with this case. It'll be very simple. But then, now I'm standing before you with two minds. What should I tell you? This is a percutaneous repair of a giant coronary aneurysm in a tortuous RCA. Each word is important. In distal position, with usual PC hardwares, using scaffold of drug regulating stent and overlapping long covered stent. My patient was a 40-year-old male, a young patient, hypertensive non-smoker, with strong family history of coronary artery disease, brought with anterior MI, ST elevation, with good LV function. He underwent primary PCI just like usual. CAG revealed severe triple vessel disease. LAD mid-acute total occlusion with tight ramus intermedius and OM lesions. RCA tight lesion, but at acute margin, followed by a giant coronary aneurysm. I'll show you the angiogram. Primary PCA and S2 mid LAD done and ramus intermedius immediately. Taken up for then ramus intermedius also done in a second after 1 day. Regarding RCA, discussed the option and they decided they went back actually. This was the thing in question. See, I was not very keen to do anything on this. So I told them there are multiple options, but each option is difficult. It can be a percutaneous option, it can be a surgical option, we can just leave it alone. So they took the CD and went to some places. Some of you would have seen. I'm quite sure. But quite unfortunately, they came back to me after 1 week saying that we need a percutaneous option. So I reanalyzed this. Now I had nothing more to do but to analyze what exactly I can do. See, we can see that it's a tortuous RCA. At least I can highlight and negotiate 3 bends here. One in the proximal part as usual, the second bend in the middle portion, and the third bend at the acute margin with a tight lesion and a large giant coronary aneurysm. So whatever things I like to take through this. And the aneurysm is 14 millimeter in the long axis. In the short axis, it's 12 millimeter and 10 millimeter in the short axis, and in the oblique axis, it's 12 to 13 millimeter. The distal vessels are relatively okay. So decided on the right femoral approach because I didn't want to go with the right radial approach. Right radial approach was the initial approach. Wiring was difficult. I took a JR 3.5 guide, just like it was into the ocean, fishing for some small fish in the ocean, going into the aneurysm. Initially, somehow managed to put it into the distal RCA, and then exchanged. Initially, whisper wire was used, exchanged with the stiffer wire. Triumph ES was used. This wire I like quite a lot because whenever I require some support, I go for this wire. Once I'm into the distal RCA with good support, you can see the cut-in effect with the extra support wire on the proximal part of the RCA. Pre-dilatation was done with 3 into 15 millimeter balloon at the toughest portion. Pre-dilated. Now, there are multiple options. I initially was planning to put in a single covered stent. But even for the single covered stent, I thought there should be something to make it, to keep it there. I had nothing to go with, no statistics, no previous experience. So I thought I'll put a firehawk regulating stent as a scaffold in the, anyway, there was a very tight lesion in the proximal portion that can reach nose. So I took a long firehawk stent, keeping both sides on the normal artery, deployed it, and you can start seeing the thrombus which has started accumulating there. Now I'll have to do everything very fast. Now with the same balloon, I checked the roominess of the RCA with the, because I had to push the covered stent now deep into this thing. So I tried a deep intubation with the RCA guide. I thought it was quite roomy enough. Initially attempted a 2.8 into 26 graph master because I wanted to finish off with one covered stent, but that was not tracking. So took 2.8 into 16 millimeter graph master, and with much of difficulty, I could get it across into the distal portion. Properly placed, deployed. Again with deep throttling and same maneuver, 3.5 into 19 graph master, covered stent with significant overlap with the first graph master. Deployed it. There was some bradycardia with this, but there was good overlap. Finally, I could seal off. This was the initial check angio at the time after the procedure. The second is the second check angio after 1 week. So this is a successful repair of the giant coronary artery aneurysm with scaffold with regulating stent to start with, and closure by 2 graft masters covered stent by overlap technique. So precise to have no endoleak using usual PCI hardwares in spite of distal position of the aneurysm and significant tortuosity in the RCA. Only anecdotal reports are available for such a procedure. Now I went back and searched the literature. There was one report of Tejas Patel with a similar technique. This is follow-up after 4 months. It's doing well. And now we have finished 7 months of follow-up. Thank you.
Great case, Balakrishnan. Well done. Have you done a CT aorta angiography before planning anything? You did a CT angio?
No, there was no aneurysm. Clinically, no, nothing at all.
CT was done.
CT for what?
CT coronary angiography to just delineate the aneurysm, whether there is a neck
No,
or anything.
What is the need of that?
No, if you can demonstrate a neck or anything, there are some techniques called stent-assisted coiling. I mean, you must have come across.
No. There are various options for doing this, but my attempt was not to coil or do anything of that sort, because he has two things. One is he is having a significant coronary artery disease there, very tight lesion. That anyway had to be. So coiling won't be good enough here. Anyway, stenting is required. So stent-assisted coiling is the other option, or ballooning. Balloon, some sort of detachable balloon. All those things are very, very clumsy and won't be giving this sort of for a sacral aneurysm may be possible, but for this fusiform aneurysm, this is not typically like a sacral aneurysm.
Great case. Can this patient be, just a minute, let me ask a question first. Can this patient be left alone on medical management? Because we have a couple of patients like this on follow-up.
Yeah, but the follow-up is not most of these patients on follow-up have some sort of complication. That is what statistics tells us.
They have angina. No, I just wanted to make one comment. In 2018, I was lucky enough to be invited to Sky in US. There, the best paper award was a case like this.
Thank you. Thank you for the nice compliment. Yeah, even madam, actually all what you call as, this is called giant. This is not an aneurysm as the usual coronary aneurysm 1 in 1000. That is not what this is. This is a giant coronary aneurysm. Anything more than 10 millimeters is giant coronary aneurysm. And giant coronary aneurysm, we don't have that much of data. The data which shows us is that anecdotal data only, but that is significant deleterious clinical implications. Okay.
Sir, excellent case, including the follow-up. Just a doubt, what is the role of the drug-eluting stent as a scaffold? We didn't understand.
Yes, very important question. See, this is like you're going into an ocean without much of guidance, okay? See, you'll have to push if you can succeed with single graph master, it would be good enough. But this is quite a large one. I was not very sure on getting a success with single one. So that was the same thing which happened also. For this two covered stents to be overlapped, I need some sort of a scaffold, some bridge, so that the first scaffold, first graph master one pushed into the distal portion and deployed. See, what can happen is that I may not be able to get into the proximal portion of that with the second one, distal portion of the second one. When you have something like a bridge, a metallic bridge, sir, this will guide it directly into the proximal part of the first stent.
I think Balakrishnan, that is not the way. Actually, you can put 2 covered stent also. But you did this technique, that is okay. But
This is exactly why I did it. No. This is exactly why I did it. See, there are 2 reasons for this. One is coronary artery disease proximal to it, so I don't want the restenosis. Second is this bridge, metallic bridge, will guide my second graft master.
Otherwise also, in a putting a covered stent, the ideal one, you have to put a regulating stent first, then you put a covered stent inside, the restenosis will come down. That is actually
That is one thing.
That reason, if you are telling, is okay.
No.
Not for,
No, my first reason was not that. My first reason was to get access into the proximal part of the distal stent. Why? Because how many of us have done covered stenting? We all find it very difficult to get it across into the position where we actually want it. Isn't it? It is not. See, I forgot to tell you, I was actually using a guidezilla, 7 French guidezilla. It was not tracking through the guidezilla, the graft master. So it is very difficult to get it across. Is very difficult. So
demonstrated, and it was easily going down.
Which one?
The covered stent was running down, not like it is not down. In your hand, it was
I take it as a compliment. Thank you.
Can I ask? I think it's this. If you see the literature, most of the aneurysms, the surgery is the treatment they have done, because probably at that time the concept is any giant aneurysm, irrespective of the size, send the case for surgery. But now, as you have shown, if it's giant aneurysm of size of around 10, 5 to 10, or you said 12, you can try a covered stent. And you not stent. Because the most important thing is ischemia, infarction, sudden death, and rarely rupture. Cannot thrombus and thrombus embolization. These are the problems with the giant aneurysms. So I think it's the
Exactly, Shukran.
treatment choice.
Most important
Previously,
complication.
most of the cases done for surgery. But if it's a very large, say it's around 15 or 20 mm, surgery is the option.
Even then, we can actually, doesn't matter whether it's 15, 20, anything, because we are doing the same way. And what you rightly said is thrombus and embolism are the most important complications of giant coronary aneurysms, not rupture. Thank you.
Thank you, Dr. Balakrishnan. We are running short of time. We'll go to the next case. Dr. Pradeep Sagar. Low contrast PCA.
Respected teachers, senior colleagues, and my dear friends. So it's a challenging case of masquerading bridge low contrast PCA. I'm presenting a case of 62-year-old male who had CAD, ischemic cardiomyopathy, CKD, severe LV dysfunction, type 2 diabetes, grade 2 BPH, old CVA. Previously CAG was done and was showing triple vessel disease with a significant lesion in the middle LAD to distal LAD and proximal LAD showing calcific lesion, and LCXOM showing a CTO and RCA. In the distal RCA, there was 70% lesion, and PDA PLV was actually diffusely deceased. So on that basis, we planned for a PCI with a low contrast PCI with a IVS guided. We wired the LAD with 2 wires, the run through wire in the main branch and run through wire in the diagonal also. Then we took away IVS catheter, and initially we took 2 normal CAG, dry cine was taken, and then later an automated run of IVS was done, which was showing a significant lesion in the distal LAD, which was about 1.79 MSA, and proximal LAD was showing a 3 MSA of 3 mm meter square, while there was a fibrocalcific lesion in the distal LAD, and proximal LAD was showing a circumferential 360-degree calcium, while the mid LAD was showing a significant myocardial bridge of 20 mm length. So the proximal LAD, as I have told earlier, that it was 3 mm meter square MSA, and the distal was 1.79. Then at the distal reference of the myocardial bridge, there was during the diastole, it was 5.78 MSA and 9.71 in proximal. During diastole and systole, it was 4.15 and 5.4. So a systolic compression index is an index which is done to identify whether this systolic compression, whether it is a significant myocardial bridge or not. So a diastolic MSA minus systolic MSA by diastolic MSA is the calculation, and you will get that systolic compression index of more than 0.1 is highly significant. In this case, we got 0.23. This was at the site of the myocardial bridge, it was 2.83 during systole, and diastole was 5.26, and a plaque burden of nearly about 40%. So we left off the myocardial bridge and we planned for doing a PTCA to the proximal LAD as well as distal LAD. Proximal LAD was pre-dilated with a 2.75 into 12 NC balloon at 12 atmospheres, and distal LAD 2.5 into 12 NC balloon at 12 atmospheres. Following which the distal LAD was stented with the 2.5 into 33 des at 12 atmospheres, and proximal LAD at 3 into 23 des at 12 atmospheres. And following which we post-dilated with a 2.75 into 12 mm NC balloon at 14 atmospheres and 3.5 into 8 NC balloon at 16 atmospheres. Following which a 3 to 4 ml dye was injected to look for any dissection, and the diagonal branch occlusion is there or not. Then an IVUS run again was done, and the IVUS run was showing a improvement in the MSA of distal as well as the proximal one, and the calcification was also cleared. We didn't touch the myocardial bridge, and so thus from the proximal LAD was about 3 mm MSA initially, it went up to 10.24, and the distal was about 1.79 to 5.17. In a US-based study which was showing the significance of IVUS in identifying the myocardial bridge was done of 331 consecutive patients. There was 30% patients with angiographically detectable myocardial bridge in this study, and IVUS showed about 75 segments, that is about 23%, and out of which about 72% of IVUS detectable myocardial bridge was there. There was no significant angiographic abnormality. So these are some of the pictures of the actual myocardial bridge with the in IVUS as well as angiogram. So vessel and lumen area in myocardial bridge segments were significantly smaller than those with the adjacent proximal and even distal reference segments. Angiographically, detectable myocardial bridges was significantly longer, located more proximal in LAD, and had more severe systolic compression by IVUS. So angiographically, silent myocardial bridges more often occurred in presence of an adjacent proximal stenosis, and those patients in whom there is a reduced ejection fraction, in similar to our case. So IVUS detectable myocardial bridges are observed approximately in 25% of the cases undergoing LAD imaging. So overall, CKD patients are definitely high-risk patients but cannot be ignored. Definitely low contrast PCI is better performed electively as a planned procedure in advanced kidney disease after 7 days of initial angiogram. HDIVUS assisted low contrast PCI is best way to revascularize LAD. IVUS is helpful in identifying angiographically masquerading myocardial bridges. IVUS provides accurate anatomic diagnosis of myocardial bridges with angiographically silent cases. Stenting should be avoided in a myocardial bridge, and never to forget some of the basic things, that is hydrate the patient before going for a PCI, perform a baseline CAG before 7 days, and then transfemoral is always better than transradial. A small guide, a larger guide catheters are more should be avoided. Only if there are like lot of catheters, wires, etc. Fluoroscopic markers, non-ionic osmolar, that contrast should be used. Least contrast volume to EGFR ratio should be less than 1. And unnecessary cath-table movement during the procedure should be avoided. And post-PCI echo, and definitely never to forget, heparinize the patient. Thank you.
Great case. Was hereditary viable?
Sir, in the sense of myocardial, that is, patient was having an STEMI, ACS, and also symptomatic. So we thought of. Sir, because in CKD patients, we have to keep up the radial side for any further, like AV fistulas, etc.
Any comments? If no more questions, great presentation.
Thank you.
We'll call upon Dr. Praveen to present his case. Have an open mind.
Respected chairpersons, friends, this is basically not to concentrate on the intervention part of a management issue we had. This was also taken up as a part of a CTO workshop. A 52-year-old male, inferior plus posterior volume in April 2022 with risk factors of diabetes and hypertension. Echo showed RWM of LAD and RCA territory, and he had also a small ostium second MASD with ejection fraction of 38%. CAG showed two vessel disease of LAD and RCA. Primary PCA to RCA was done from an outside center, and then he came with for an LAD CTO. This was the first attempt, a fine cross microcatheter, fielder XTA wire, Gaia second, Conquest Pro was used in the antigrade attempt initially. We stopped when the fluoro time was around 40 and the grays were exceeded and dye limit was also exceeded. So July 22nd, that attempt failed. So we moved on to the second attempt in October 22. Again 7F EBU3, fine cross microcatheter, again fielder XTA, Gaia third and Conquest Pro 12. Again, we failed in that attempt and was taken up for the third attempt in April 2023 as a part of the CTO workshop. 7F JR and 3.5 and 7F EBU in left side. Again, went for the antigrade approach. Fielder XT, Gaia, second and third, failed. So we moved on to the retrograde aspect. And then again, retrograde wire went outside the lumen. It was not in the true lumen. So again, dropped that attempt and went back and went in for an antigrade repeat attempt with crusade microcatheter and Gaia wire. And this time the wire was into the true lumen. And then we stented with the 3x24 drug-eluting stent. The final issue was that only that the diagonal wire came out, and then we could not recross into the diagonal. So we thought we'll leave the diagonal as such with a TME2 flow in the diagonal and a TME3 flow in the LED. Further course was a 2 hours post-procedure. Patient developed shortness of breath, hypotension. Echo showed moderate pericardial effusion with early features of tamponade. Pericardiocentesis of 300 ml fluid removed. Pigtail catheter was kept and removed after 4 hours after a repeat echo. Observed for 3 days and discharged. It was discharged on dual antiplatelets and other medications. Review after 1 week in the OPD, patient was asymptomatic. But the story doesn't end here. About 28 days later, a patient presented with one episode of LOC to the ER at 6 a.m. History of recurrent episodes of giddiness, chest discomfort, and diaphoresis of the last 2 days. Pulse rate was 88, BP was on the lower side. Heart sounds was not muffled, but no murmurs. ECG showed sinus tachycardia. Trop was negative. This was the echo. The echo showed again effusion, large collection. Again, pigtail was inserted. Then what happened is that the next 20-25 days was really difficult for us. He had repeated collections, hemoglobin drop. We needed to aspirate around 1 liter on few days. Then 13th, 14th of May, we had around 1 liter of fluid, pericardial fluid drain. Hemoglobin dropped from hovered around 6. He had around, and in between, we were in doubt about this recurrent effusion. And the ANA1 result came as positive, so we went for the ANA profile, which was negative. BNP was positive, CRP was positive. Other causes for the repeat effusion were also looked into, like malignancy. The malignancy workup came as negative. So throughout this 20-25 days, it was difficult to manage the patient as well as a bystander because we had no explanation to give for the recurrent effusion and the ongoing pericardial tap that we were doing. And again, a CAG was done, showed patent stents in LAD and RCA, no perforation noted. Started on injection methyl prednisolone. 14.5 he had a transaminitis. Aspirin was stopped and continued on single antiplatelet. Chest CT was sent, which showed again bilateral pleural effusion and moderate pericardial effusion. Even an RV angio was done, suspecting that we had inserted the pigtail into some other RV or any injury in that aspect. The pigtail, the CT angio also did not show, and the RV angio also did not show any effusion. IV antibiotics was there throughout. He was also started on tab colchicine, 0.5 milligram for around 33 days. Methyl prednisolone was tapered off and started on oral steroids. 11 pints of packed RBC was given. Single antiplatelet initially, and then was dual antiplatelets on follow-up. The pigtail was removed about 22 days after the effusion in the initial insertion, and he was discharged after around 30 to 35 days of hospital stay. So what is it? that we were dealing with. So possibly post-cardiac injury syndrome. That's a pleuropericardial inflammation and effusion syndromes after traumatic mesothelial injury to the pericardium or pleural cavity. That might not be always related to the MI alone. It can happen even in patients post-cardiac. After perforations, data has been reported. After coronary dissections, the post-cardiac injury syndrome has been reported. The incidence is in this article is around 0.5%, and it is said even up to after 6 months after the index procedure, this can happen. So we thought in this lines, the diagnosis of post-cardiac injury syndromes, you have the criteria, 2 of the 5 clinical criteria, that fever without alternative causes, pericardial or pleuritic chest pain, pericardial or pleural rupts, evidence of pericardial effusion, and pleural effusion with elevated CRP. Our patient did match this. So the treatment is a multi-pronged approach, anti-inflammatories. The recurrence rate is around 10 to 15%, and the patient has a risk of constrictive pericarditis, and long-term follow-up is needed. Echo 2 weeks after discharge, he is doing fine. And later, 3 months echo after the index procedure, he started slowly showing features of early constrictive pericarditis. Thank you.
Very interesting case. If I can borrow the terminology from Pradap, the first investment procedure was in 2022 June also.
And on the first in July 22.
And the successful procedure was done after 1 year or so.
Almost 1 year, sir. Almost 1 year. 8 to 9 months. July, October, and then April 2023.
I think that patient is very symptomatic, probably. No?
Yeah, yes, sir. He was symptomatic.
Very interesting case of post. I haven't come across any pericarditis syndrome after stenting and all. And I don't know the experience from.
One case I encountered is not related to pericarditis or cardiac surgery, but it was a case of inadvertent thrombolysis, and the patient was chronic alcoholic, and there was a pericardial effusion, and we worked up, and the patient was giving history of chronic alcoholism. So we did the pericardial fluid aspiration, followed that sent for serum amylase, pericardial fluid amylase. So it was a pancreatopericardial fistula. That patient was sent for GI surgery.
Thank you, Dr. Abdul. Nice case.
Thank you.
So a coffee tea is available on adjacent hall. It will be available for 1 hour.
Next, we'll invite Dr. Praveen GL. Leap of. Where's Praveen? Praveen GL?
Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity. This is a story of a 59-year-old male, hypertensive and diabetic for more than 10 years, came to us with unstable angina, echo showing good ejection fraction, but with a creatinine of 1.4 with an eGFR of 58. We proceeded to ultra low contrast angiography, which we took only 3 projections without panning under low magnification, which showed distal LM bifurcation lesion, Medina 111, and mid RCA there was a thrombotic total occlusion. Initially, we took care of the RCA with 2 diagnostic stents, and we used only 50 ml of contrast, so that qualifies for a ultra low contrast PCI. Despite this ultra low contrast PCI and periprocedural hydration, patient developed AKA, and the creat went up to 2.1, and the eGFR fell down to 36. So we planned for a zero contrast LMCA bifurcation PCI up to 3 weeks using decay crush technique. Right femoral axis, 7 of EBU 3.5 guiding catheter. We could engage the catheter and it was confirmed. And we wired the LCX to OM, keeping this reference image. Then we tried to wire the LED, but it was difficult. As we can see, there are a lot of branches coming out of that point. So we parked the IOS catheter in the LCX and we did the wiring of LED using IOS guidance. So we parked the wire in the distal LED. Next, we wired the septal branch. We could wire the septal and park the wire in the distal septal because it is important to skeletonize the whole coronary system in order to do a successful zero contrast PCI. Coming to IOS pre-run from LED, we showed a diffuse fibrofatty plaque with spotty calcification. So we decided to use a cutting balloon. We kept on storing cine images during the run, and that will serve as a co-registration. Coming to the vessel diameter, distal reference diameter was 3 mm. At the septal branch, it was measuring 3.6, and proximally, the LMC was measuring 4.5. So we thought of using a 3 millimeter stent distally and proximally a 4.5, 3.5 millimeter stent. And the tighter segment was measuring an area of 3.2 millimeters square. Coming to the lesion length, from the ostium up to the septal branch was measuring 36 millimeters. So we thought of using a 38 millimeter stent so as to flare the LMC ostium. And distally from the septal up to the distal landing zone was measuring 25 millimeters. And we plan to use a 28 millimeter stent for a 2 millimeter overlap. We predated LED with a 2.5 NC followed by a 3 millimeter cutting balloon. After that, we took a run from LCX, which again showed a diffuse fibrofatty plaque. And we again decided to use a cutting balloon for LCX also. And regarding the vessel diameter, distally the reference diameter was 3.19. We plan to use a 3 millimeter stent. And tightest segment was 2.62 millimeter square. And the LCX ostium was significant with an area of 3.06. Coming to lesion length, from the ostium up to the distal landing zone was measuring 30 millimeters. And for the proximal crush, we decided to use a 33 millimeter threads. Radial to the LCX is 2.5 followed by 3 millimeter cutting balloon. And the stent was parked in LCX with a 3.5 NC balloon in LED. A stent was deployed. And sideward branch optimization was done with the stent balloon pulled back. And crushing the stent using a 3.5 balloon. And port crush was done using a 4 balloon, keeping the stent edge just before the carina. It could recross through a non-distal strut, and side branch of ostium was opened with 2 balloon followed by 3 balloon. And first kissing balloon dilatation was done using a 3.5 millimeter balloon in both vessels. Then we took out the LCX wire and it was kept as the marker for the aortic sinus that will guide us to decide the proximal ostium of the LMCA. And the stent was placed 3.5 to 38 does. The stent was placed in the LMCA and stent was deployed. And ostium was flared using the stent balloon. And first port was done with the 4.5 millimeter balloon. And the second stent was deployed with a 2 millimeter overlap in the middle AD. Again, recrossed through a non-distal strut. Serially dilated with 2 balloon followed by 3 balloon. Then serial dilatation followed by second kissing balloon dilatation with 4 balloon in LED and 3.5 in LCX. This is the final port with the 4.5 balloon. The final I was run from LED, the distal end edge is perfect, no dissection. Mid LED MSA was 5.25, the proximal LED was 7.69, and the distal LMCA was 11, and proximal LMCA was 11.5. From LCX, the distal standard edge is perfect. Also, LCX was measuring 5.71, and in between we found an area of malopposition which was corrected with a 3.5 millimeter non-compliant balloon. This is the final result, and this was taken with a 2 ml of diluted contrast just for insurance approval. Patient did not have any symptoms like chest pain or ECG changes during procedure. Serial echo during and post procedure was showing no complications, and serial creatinine values range from 1.6 to 1.7 during hospital stay and 28 days of follow-up. CAN has a significant impact on long-term prognosis and is independently associated with higher mortality. In patients with higher risk of developing CAN, zero contrast angioplasty with IOS guidance is safe, effective, and renoprotective, and it improves the PCR results both short and long term. With systematic analysis, IOS can replace most of the contrast injections in PCI. The only thing worse than being blind is having sight but no vision. We were blind throughout the procedure, but we had the vision to use this great tool and make the life of a kidney disease patient better. Thank you.
Excellent demonstration of zero contrast PCI. Congratulations.
Any comments?
Yes, sir. So in order to get the full view of the vessels.
I mean, in zero contrast PCA, is it like that we should not use any contrast at all? Because even nephrologists say that some amount of contrast is, they calculate according to the GFR and the things, that much of contrast.
Actually, that is called ultra low contrast. If your actually the contrast usage is less than the EGFR, it is called ULC. Basically, you can use 3.7 times the EGFR in any case. Normally more than 90. So 90 into 3.75, it is nearly 300 to 400 ml. Everybody can use. But if you go to the ultra low contrast, that should be less than EGFR, contrast volume. But we as a principal in our hospital, I don't touch. This injection is not taken by us, me. I will not touch the contrast.
But
When I
what
do-
I'm asking is that whether it's like we should not touch the
See,
contrast
actually
at all.
not
At
touch-
least you can use some 10 or 20 ml of contrast.
No, no,
to
no.
make-
I will tell you
to
this.
make just to be on the
Umesh,
safer
Umesh,
side.
I will tell you the story again. If you do ego of the patient. Person. No, Umesh, I'll tell you one point. There are patients who come with a 12 ml of contrast, some other hospital, with 1.7 or 2.4 creatinine. Next day, that is creatinine gone up to 4.5. So I personally feel that even 1 ml of contrast can be dangerous. But if you have a doubt, you can always check. But you restrict your contrast amount to below EGFR. Number one. Number two, most of the cardiologists as a routine, what you learn is I will take LAO-caudal, AP-caudal, RAO-caudal, RAO-cranial, LAO-cranial. For what purpose? Whatever you want. Maximum 3 injections, finish it off. And with 15 ml of contrast, you can do an angiogram for a patient. But that is the message we should give to the public.
Use the
bare-
minimum amount of contrast
It can
usually, and
reduce-
only use it if it is judiciously use it basically. Okay, we'll move on to the next. Great presentation, great case. Thank you. We'll go on to the next presentation by Madam Rajlakshmi Madam on functional assessment.
Good evening, respected chairpersons, teachers, and my dear friends. Compared to all the complex cases, this is a relatively simple case. The patient is a 66-year-old male with CAD, ACS, and STEMI. He was diabetic for more than 25 years, hypertensive, and there is a history of balloony amputation 2 years back, and he has a history of CA prostate on chemotherapy. ECG showed T inversion in the inferior leads, and the echo showed wall motion abnormalities with fair LV function. He was taken up for angiogram. Angiogram showed double vessel disease. The LAD was showing 60 to 70% lesion in the mid part, and the RC was occluded, and the distal RCA was spilling. The collaterals could be seen in the left injection. So we planned for an assessment of functional assessment of LAD lesion, which looked intermediate with the DFR, which is a diastolic non-hyperemic ratio. And the LAD DFR was 0.82, which is significant, DFR cutoff being 0.89. So we decided to open up the RCA first and then assess the intermediate lesion of the LAD. So RCA PCA was done with, because it was totally occluded and it is not an acute MI, we took with a SCR guide cath, and a field XT A wire was used, and the lesion was crossed with microcatheter support. And after crossing the lesion, the field XT A wire was changed to cyan blue, usual routine wire, and the RC was pre-dilated with 1.5 and 2 mm balloons, and subsequently it was showing residual lesions. It was dilated with 3 into 12 NC balloon, and it was stented with a 3 into 40 mm drug-eluting stent. And it was post-dilated with 3.5 into 12 mm NC balloon. And after fixing the RC lesion, we did a functional assessment of the LAD lesion again, and the DFR was 0.87. It had some improvement, but it was again significant, cutoff again being 0.89. So the LAD lesion was then fixed with a routine angioplasty. LAD was wired, it was pre-dilated and stented. So this is just to highlight the importance of functional assessment in intermediate coronary lesions. Yeah, the take-home message is to highlight the importance of functional assessment when you have intermediate lesions, when the vessel is supplying collaterals to the opposite territory and supplying a large area. Such cases, fixing the lesion in the occluded vessel and then Assessing the lesion by functional studies is recommended. This is to avoid false positive results with functional studies when you have insignificant lesions and the vessel is supplying collaterals to the opposite coronary as well. Yeah, thank you.
Nice case, madam. Excellent demonstration of role of FFR assessing borderline lesions. Any questions from the floor?
Yeah, I did.
Thank you, ma'am. Invite the next presenter, Dr. Praveen Sri Kumar.
Good evening. I'll be presenting I'll be presenting a case of BRS in a multivessel coronary disease. This is a 70-year-old lady with presented with anstomy, good LV function, EF of 50%, and a creatinine of 1.1. She was medically stabilized with heparin, DAPT, high dose statin, and beta blockers. An elective coronary angiogram which was showed three vessel disease, and she was taken up for PCA. The angiogram I'll do as a part of PCA. This was a LAD lesion, and this was pre-dilated. It's a long LAD lesion throughout from distal to proximal. The distal to proximal dilatation was done with 2.5 into 12 Icck force balloon serially from distally to proximally, and this was a full pre-dilatation view of LAD after pre-dilatation of LAD, and the LAD was tended with from distal to proximal. Distally, we used 2.75 into 29 Meres 100 biovascular scaffold. And proximal to this, with a tip-to-tip implant, we implanted a non-overlapping. We implanted a 3 into 24 Meres in the mid LAD, proximal to mid LAD. So this was a tip-to-tip implant, but the markers just overlap, not the stents. Markers are inside the stents. And so this was the final result after the LAD. And proximal LCX lesion was, there was a single LCX lesion that was treated pre-dilated with 2.75 into 15 millimeter lineage balloon dilated to 12 atmosphere and stented with Meres center of 2.75 into 19. That was a short lesion, post-dilated with 3 into 15 lineage balloon at going up to 18. And RCA was RCA was a tight lesion in the proximal part, but long lesion, pre-dilated with 2 into 10 Rayure and lineage balloon, and with 3.5 into 15 millimeter balloon at 12 atmosphere, and stented with 2 stents. Mid distal RCA was stented with 3.5 into 32 millimeter Meres 100, and proximal was done with 3.5 into 29 millimeter Meres 100. So finally, follow up. This is a full metalless PCA, but follow up after 6 months. This is a OCT follow up after metalless PCA after 6 months. This was a LAD pull through of the OCT showing partial resolution of the LAD stent struts, and there's a good golden tube developing, and this was a LCX pullback, also showing a very good metal tube formed partially and partial resolution of the stent struts. And this is the RCA pullback. This is a part of a distal RCA, and this is where the stent starts. And now the metal tube is forming. This part shows a metal tube which is being formed, and partial resolution of stent struts. So this is just a demonstration of a metalless PCA, 6 months OCT follow-up. Now it is actually 1.5 years. Patient will come for a 2-year OCT follow-up in December. So probably metalless PCI, people who might benefit are young patients. We do it for type A lesions, young patients who have a very discrete lesion on OCT showing after pre-dilatation showing very normal segments, otherwise the lesion. So in such cases, that's what we take. This was a case where we just opted for a BRS because after pre-dilatation and OCT, at least some part of the vessel looked normal, except LAD. So probably you should be cautious in primary PCI and lesions containing thrombus, or it can be done at least in a stable patient with a very low thrombus burden. Otherwise, primary is not a good option for metalless PCI. Aorta-osteal lesion should never be taken for a metalless PCI because chance of an embolic CVA when the struts dissolve over time, that risk is there. So conclusion is completely metalless PCI in a multivessel PCI is feasible, in a suitably, carefully selected patients. Thank you.
Nice case. Why BRS and what some in the past absorbs stents, no? We have found some
Yeah, this was
aneurysm
done
formation
earlier.
and all. So what is the long-term follow-up of MERS? Because in the past when we had absorbed biodegradable scaffolds,
Long-term follow-up,
long-term follow-up we found aneurysms.
aneurysms were there.
But what is
Aneurysms
the
were-
long-term follow-up of MERS?
There are no long-term follow-up from us.
So why BRS in this patient?
No, the thing is, it was normal. We were just started using the thing. So after the lesion was dilated, we thought we'll use BRS. That's all.
Yes, part of the study or anything, something like
Yeah,
that?
we thought.
Yes, part of the study. Yeah. No, basically, at the time of implantation only, you like to, basically, it's all OCT based,
OCT
based, pre and post. Great case, Ravi. Well done.
The dye staying there, or was it thrombus attached to the?
That was dye staying. Yeah, yeah. No things. I told them we informed the patient carefully.
Patient will be willing for the angiogram over the next 2 years so that they are actually having no stent inside. Angiogram is now considered as a angiogram is just like an IV injection, sir, now.
Thank you, Prabhu. Last case of the session, spiral decision, how to tackle, to Dr. Anup Gopinath.
So this is another case where this was actually a road traffic accident that occurred in front of my hospital. There was a head-on collision between a bus and a car, and the person in the car was brought to our hospital. He had a fracture of the left clavicle, a compound fracture of the left femur. There was contusion of the chest and facial injuries. He was shifted to the orthopedics theater immediately, but they found that he was in hypotension, and the anesthetist took an ECG. ECG showed an acute inferior wall MI. So he was shifted to cardiology, where we saw the echo. Echo showed a global LV hypokinesia with a severe LV systolic dysfunction. So this was the echo in the patient. The LV is hardly moving. So I decided to take angiogram. In the left shots, LMCA, LCX, and LAD were all normal. In the right coronary injection, you can see after the RV branch, there is a tear in the right coronary artery. It goes all the way up to the crux. Now, if you see, if you clearly note the dye passing, you fairly will think that the true lumen is the one that goes from the upper side. It goes all the way distally. I tried wiring that part, but found that there was resistance. So I immediately stopped and I tried to wire through the least possible lower part. And now you can see in the lower part, see, the wiring is done through the lower part. And finally, I think I was able to get the track. Finally, I entered into a side branch. I came to know that we are in the lumen. Following which, the normal balloon was not going through. So I took a 1.25 into 10 millimeter balloon, pre-dilated it. Then I successively pre-dilated with a 2.25 into 10 millimeter pre-dilatation balloon. And with a 4.7F guide plus support, I deployed a 2.75 into 40 millimeter stent from the after the RV branch on distal to the crux, and it was dilated, and the entire thing was post dilated with a 3 into 8 millimeter post dilatation balloon. Immediately after I did this angioplasty, I think the blood pressures picked up immediately, and patient was shifted to the ICU. After the pressures were stabilized, in this there was slight improvement in the LV function immediately after the procedure. This was, I think, day 1 of procedure. On day 2, after 48 hours, patient was taken up by the orthopedics team, and without stopping the antiplatelets, they did both the femur as well as the humerus in the same setting under anesthesia. The only problem was that they did not shift the patient to the orthopedics department. They kept it under me. Again, the problem was that the drain could not be removed for 10 days. It was only on the 12th day we were able to remove the drain. In this patient, the LV function totally normalized after 6 weeks, and the patient returned to his job in 4 months. Thank you. No, there was nothing in the LC. It's normal.
There's a traumatic RC,
Yeah,
RC
traumatic
dissection.
RCA dissection.
dissection. Fantastic case.
Can you explain the severe LV dysfunction based on
Yeah, it's
this?
stress cardiomyopathy, probably. Stress
Takotsubo.
It's very
Takotsubo.
likely to be stress cardiomyopathy, and the lesion that you've stented is very likely that it's a recanalized thrombus.
Yes.
It might be a very old occlusion and a flow through that. Very likely, Anup, because you had difficulty in wiring it, you had difficulty in negotiating the balloon there, you had difficulty in getting the stent across, you had to use a guide extension. It's very very likely that it's a recanalized thrombus. Now imaging would definitely would have picked it up, but then we couldn't do an
Patient
imaging.
was in hypotension and patient was not coming out.
So this is probably an innocent bystander. And again, in this, sir, one second.
Scared. Why not scared?
It's very unlikely, sir, because he had difficulty in wiring. He couldn't get the.
No. I had no difficulty in wiring. There was absolutely no difficulty.
So he had
I
difficulty.
went through the false lumen initially. I took out the wire and then went through the other, and it went distally. There was no problem.
Your balloon was not tracking
No,
in.
that is because the false lumen probably would have been filled with a large gut of hematoma.
You had to go with a 1 point, very small balloon.
Yeah.
And the third thing, again, you had difficulty in tracking the stent.
No,
So,
I didn't
sir,
have a
it's very
difficulty. I
likely-
used a guide plus to
And
take
Deepak,
along.
why is it not a traumatic dissection?
Whether the ECG
Dissection, it
changes
goes
settled
in-
after the
everything goes in without any difficulty.
Anup,
No, why ST elevation in
Anup,
2-3 AV
whether
is
the-
now?
whether the ECG changes settled after
Scan
the
can explain.
Yes,
different things.
ECG settled immediately
Difficulty
after doing
falls
the.
to true lumen, difficulty getting it, all this thrombotic thing, all can be happening.
No, initially when I was wiring, I was in the false lumen because I found resistance. That's why I took out the wire immediately, and there was only two.
Anup, in SCAD,
purchase.
you have the false lumen, isn't
Yes,
it?
yes, that is what.
So if it's SCAD, you don't necessarily have to do a stent.
Yes.
You could have just.
No, because this patient has acute inferior wall myocardial infarction. We are justified to do a stent.
This
If it
could-
is a chronic case, only based on
Agree.
ischemia.
This could be LV dysfunction, could be secondary to stress cardiomyopathy.
Stress cardiomyopathy,
But
yes.
definitely, as he's saying that he had an ST elevation, he had hypotension, and the ECG settled after the procedure, and his hemodynamics improved. I think we should take it as an acute inferior wall myopathy.
I think it's a classical iatrogenic dissection, and one part of SCAD is intramural hematoma. And basically, just like in aorta, the coronary intravascular hematoma, somewhere there will be almost like a pinpoint area. That is the area you are getting difficulty to pass the balloon. So thinking that it's all acute and just
Why should you
SCAD
say,
and
why it is a iatrogenic dissection?
No, it's a traumatic.
I mean, it's a
So,
trauma.
yeah, blood trauma kind of, because the RCA, the mid part of the RCA is the external to the heart, not the intramyocardial. Majority 80% is the outside the heart, and this is the classical set. You can get an IMH as a part of SCAD, and these sort of IMH you have to stand entire length.
Yeah,
other
another-
than the dissection part.
Another thing is always in SCAD, imaging is must, because
definitely.
I have faced a
IVC,
problem earlier where I got a 20 millimeter spiral dissection. I used a 32 millimeter stent across a spiral dissection, found proximally that there was, it was actually narrowed. There was a tubular stenosis proximal immediately after putting the stent. So I didn't get the site of the rupture. So
basically,
I was,
basically the role of IVC is
Yes,
whether to
length.
stand the only the entry part or not. If it's IMH, you have to stand entire
Hold,
length
hold.
of the vessel.
And the stenting should be done fast, otherwise the intramural hematoma will track to the bed. So that will create.
Thank you, Dr.
Nice case, nice case.
One last question, Dr. Mahesh.
No, that's because of stress cardiomyopathy. No, the vessel closed and he was in stress, yeah.
Yeah, the excellent case. It could have been presented here, like you presented. If you had not crossed, it would have been nightmares in cath lab.
Yes.
Thank you, Anup. We are running short of time. I think we'll close this session and go to the next session.
Thank you, Ananjal. So we are moving on to the next session in 2 parts. So firstly, structural interventions, session 1. Requesting the chairpersons, Dr. Vijulal, Dr. Ramakrishna Pillai, Dr. Shafiq Matumal to join the stage. Please come forward. Please occupy the chair.
So let's start this session on structural heart interventions. First case is an interesting case of structural heart disease intervention by Dr. Vijay Kumar. Okay, then next case is mitral clip in degenerative MR. This is probably only a couple of cases done in Kerala. Let's hear from Dr. Praveen.
Good evening. Just a case of mitral clip in a degenerative mitral regurgitation. The patient was a 75-year-old male who had a known mild MR on follow-up. History of coronary artery disease with a history of revascularization and before. And of late, he had a progressive worsening of dyspnea for 2 years, and he was advised MVR elsewhere, but it was turned down basically with the surgeon because he had COPD, kyphosis, and frailty. And then he was pulling on medical management, and echo showed severe MR with MVP. Almost 6 months he was with severe MR and he was not willing. And finally he agreed for the mitral clip. So basically the first thing is you have to have a biplane view, that is a bicommissural view and an LVOT view for planning the procedure. So basically that shows the prolapsed PML in both the views and the jet of mitral regurgitation, which is basically on the medial aspect of A2 and P2. So the pulmonary vein flow again shows systolic reversal, and the 3D NFAS view basically shows the prolapsing leaflet. The first thing is, of course, the septal puncture, and as yesterday Arun Gobi had told, it's basically a posterior puncture and inferior puncture, and it is basically two views. You have the tending in the bicable view and the short axis view, and then you do a posterior puncture, and you should have an adequate distance from the mitral valve, around 30 or 40, 30 to 40. Then once we have that, you cross across and you have the sheath delivered, and on that sheath you have basically the guiding catheter with the clip inside. And once that clip has gone through, basically the further part of the procedure, it is basically through fluoro guidance and a TE guidance. It's more dependent on TE. And then you negotiate the clip, which is straddled and maneuvered towards the medial aspect so that that faces the mitral leaflets. And then you have to have a good perpendicular alignment of this clip, and that is basically to ensure that it's strictly going perpendicularly, and that basically use these two views, and you ensure that goes perpendicularly across the mitral valve into the LV, and that is again confirmed in a 3D TE, which is very useful for the confirmation of the position. And then you have to actually maneuver by fine movements to make sure that is actually over the prolapsing leaflets. And then once that is exactly over the prolapsing leaflets, then you basically dive into the LV. And here you should be careful, you should not be going too deep so that you should not catch the chordae. And once you have the position confirmed, you have to grasp the leaflets. And once you grasp the leaflets, as you can see in the extreme right image, you grasp the leaflets and you ensure that the grasp is adequate by again seeing for the MR. And then once you see there's an appreciable reduction in the MR, you can release the clip. And that basically image shows the good reduction in mitral regurgitation and the clip is released in place. And that shows the final result, where you can clearly see that there is almost only a trace of mitral regurgitation and the clip is in place. Now the patient is almost like 8 months of follow-up and still coming in for follow-up. The LV size is reduced. Mitral regurgitation is only trace, and he's almost like class 1 to 2 now. And he's not on any diuretics. Thank you.
Excellent case, Praveen. Congratulations. And what was the echo gradient, transmitral gradient after the case?
Yeah, it was verified. There was no significant gradient. That's also an important thing you have to look at.
Yeah. For an academical purpose, what kind of MRs that you consider working up for mitral clip?
Basically, either a degenerative mitral regurgitation or an ischemic mitral regurgitation, where it's a severe MR and patient is not a candidate for surgery.
Which clip was used, G3 or G4?
It was G3
And
XTR.
what is the your ACT level you require for this
It was
procedure?
maintained almost 300 around the
What's the
procedure.
recommended?
They maintained about 250. It was frequently checked. Actually, ACT was checked almost like once in 30 to 60 minutes.
How much time did it take?
This took so much time because we had to grasp almost like the third grasp was on, which gave a very good reduction mitral regurgitation. So almost like 4 hours it took.
How do you, sorry about my voice. See and listen, but don't speak much. How do you decide about a second clip?
So I can't hear you. Sorry.
How do you decide about the second clip?
That's if the MR has not appreciably come down, you can deploy one more clip actually, basically. In this case, there's an appreciable reduction only to less than mild MR.
One thing Praveen must have done, but he has not shown is he has put a pigtail in LA. So there's continuous online LA pressure monitoring.
It was
So you actually have the baseline LA pressures. You see the reduction of LA pressure. So it's an online monitoring. He has a pigtail in. Probably he didn't show it. That's only. Otherwise, the reduction of LA pressures is the actual direct investment to see whether you need an additional clip or not. Because the MR, the view in which you take might be violation, but you look at the LA pressures.
Sir, a second or third clip is also free. Then there is no problem. You can actually put 1 or 2 clips more. Don't create MS and just create only close-up.
It is a T-gated puncture. It's a T-gated in bicable view as well as the aortic short axis view. Yeah, he uses, but we did a T-gated puncture.
Thank you, Dr. Praveen. The next would be TMVR by Dr. Muhammad Amin.
Good evening, all. I would be discussing our recent experience with TMVR. So my patient was a 70-year-old lady. She had a history of rheumatoid heart disease, predominantly severe MR and mild MS. And she underwent mitral replacement in another hospital with 27 Perimount Magna valve along with CABG around 10 years back. Now she presented with incidence onset class 3 dyspnea and peripheral edema. On evaluation, she was found to have severe prosthetic valve stenosis with severe PVH and PAH with RV dysfunction. So this was echo image of this patient showing severe mitral valve stenosis with mean gradient more than 15 with smoke in LA. So with severe stenosis of this prosthetic valve. So considering multiple comorbidities and very high surgical risk, after discussing with family, we proceeded with the TMVR. So pre-procedure, we did a complete transesophageal echo and a CT for LVOT assessment, predicted LVOT area. So we did a femoral approach, both femoral veins and an arterial line. The case was done under GA with TE support. So we did a septal puncture with this again the site-specific septal puncture posteriorly with a biplane view. So we entered the LA. The same was confirmed using the fluoroscopy. So we did we inserted a PTMC wire and then we dilated the septum. And again we inserted an Agilis sheath and then we entered the LV using a pigtail catheter. Then we kept the stiffer in the LV across the mitral valve, prosthetic mitral valve. Then we did a prosthetic mitral valve valvuloplasty using a mammoth balloon 16 mm. Using the same balloon, we dilated the septum twice. Then we tracked the same balloon across the septum to ensure the trackability. Then we loaded a 27.5 Merrill my valve with a navigator system. Then we tracked across the septum, across the mitral valve. The central marker we aligned across the annulus of the previous valve. Then we deployed with the support of rapid pacing at 140 beats per minute. Then we had a good result with no migration, no paravalvular leak, or no LVOT obstruction. Then the entire system was removed. The access site was closed using a figure of 8 silk suture. The patient was extubated within few hours and was shifted to room next day and was discharged on day 2. So this is the post-procedure image. There is no residual stenosis. There is no paravalvular leak. There is no LVOT obstruction. And absolutely no gradient. The residual gradient was 3 only. So this is the post-procedure image showing well-moving valve leaflets. We can compare with previous valve. So this is our team. Thank you for patiently listening.
Great case. I mean, how did the right ventricle and the pH improve over time? Did you have a follow-up echo?
So she had slight improvement in RV function, but the pH was again severe with RVSP around 65 plus RIP at discharge. So we have followed the case after 1 month. She had slight improvement in pH also. She's doing well symptomatically.
Yeah, technically speaking, the site of the puncture, nice flossing of the partially inflated balloon on the site so that your device goes in freely, and an 80-20 in the LV side with the new prosthesis and good dilatation. Great case. Congratulations. Any comments?
What size balloon is required for dilating that septum?
We did a 16 mm we used, not completely
What is the
inflated.
recommended size? How much should you dilate?
So across, this depends upon the valve you're using. So we used a 27.5. So we used with 16, but we suboptimally we dilate. And we tried the trackability also with the same balloon.
So what's the predicted LVOT area below which we will not do it?
1.7. This is Merrill my valve. It's an octaco.
Thank you, Dr. Amin. Next, we have one more TM we are coming up from Dr. Ashraf. We have an evaluation sheet here where we will be valuing. So we have 2 similar cases.
Thank you. Basically, these just like the previous case, but a few technical difficulties. The patient is 75-year-old male and status post MVR bioprosthetic valve, same perimount valve 2014, and actually it's a patient angioplasty then followed by this MVR did almost 9 years. Now he admitted with severe prosthetic MR and mild restenosis and severe pH and dilated LA with normal LV function. And the Trementia showed the good LVOT and new LVOT is almost like 300 to 400, 350. So the valve size is 30 mm. And so we decided 30.5 for the procedure, just like the same Magna valve. And there was some difficulty in that, the puncture with the T guider only. And you can see that the same tried with the pigtail and entered into that, and followed by replacing with the LA wire and dilating with actually the question was ideally if you are using the Sapien valve, then you can use the 12 mm balloon, but you can go up to 14. Only issue if you oversize the 14 and 60, there will be septal dissection, and inferior and superior it can cause pericardial effusion and perforation. So again, the only issue with the flossing method is you can make half inflated balloon and go in inflating. The only issue is you can make a thrombus and embolism. So the cerebral embolism, so that's slight risk is there. And here why the importance we had to use the 30.5 intermediate size of my valve. So intentionally did that flossing. And now we attempted with that, the valve is not moving with that. So we decided to, with the Safari, then followed by it is not going through the extra short Safari wire. Then we decided with the AV loop formation with the hard wire of the Termo. Again, we tried, it was not going. The valve is not negotiating. Then after that, third attempt, we used this one, Landerquist wire and with an AV loop. And there is a risk of, there's a section, the cutting of the aorta mitral area. So judicially, we tried with the pushing of the valve. I will show the video how it was very so difficult. So this negotiate took almost 10 minutes how to. So puncture was posterior, little bit superior also, but still there are difficulty. Ultimately, took longer time to push that. And again, the classical of 80s to 20, the 80 in the LV area, 20 in the LA area. And the alignment was not proper because it is going to the middle part of the magna wall. So ultimately, after pulling out, we got it very good area. Good position with the alignment in the middle and lateral part is aligned in the single plane and got a very good inflation. So you can see that completely inflated. So this is the final result. And it just show that, so there was difficulty while pushing because the LA part, if you take the anatomy of the LA, the superior part will be thinner when compared to that part. Next near to the appendage will be more thinner. So this is the puncture area, posterior, and little bit superior also. And you can see that the last moment, I just want to show that there are difficulty to take, there is an arterial tortuous in the vein and the artery, and even Lunderquist wire is making as an AV loop was so difficult, not easy as so different, changing because the LA was so huge, so we changed the direction of the loop of the Agilis sheath and that wall. Ultimately, we got it. So very good result. So that was that case and very good result. I just forgot to show the this one. So this is the second case. That is the hybrid case. That's a 40-year-old male with a status MVR 8 years duration and hospitalized for recurrent heart failure and severe PH and congestive hepatopathy with the deranged INR and mild thrombocytopenia with a comorbid condition. So the surgeons reluctant to take the patient because INR was always high because of the congestive hepatopathy. Again, you can show report showing the almost 27 wall with a LVOT almost more than 250. So new LVOT we can able to do the procedure. If it is less than 150, not 170 to more than 200, we can always do this case. You can see that the importance is you can see that LA is so huge and the RA is so slit leg. So here importance is the how to puncture, because if you take posterior puncture, you may end up in like stitch phenomena. So it is very, very difficult. So CT guidance, there will be a lot of issues. So cautery guided puncture with a T guidance, and the puncture took almost 1.5 hours, multiple puncture, because the RA is so small. So here again, the issue is you can see that just like pericarditis, it's a huge LA completely, and it is not co-aligned with the wall. This is the this is the biocore wall, and you can see that, and it is that Agilis sheath, and the catheter is not going to the valve area. So took longer time to cross that. And ultimately, with the help of the surgeons, the transapical route, the technical beauty, large, huge LA. So again, CT is important to where because of huge LA, the heart will shift to posteriorly. So the usual transapical site may not be the true if you follow the usual anatomy. Then CT guide us. CT is the transapical part will be little posterior. Then put a transapical put. Then put a wire. Judicious use of the sheath, and you should not go through the chordae. Otherwise, there will be issues. That caudal entanglement can occur, and you just inflate the balloon and go through the chordae to avoid whether caudal entrapment is there. Then go in the LA. Then take this one AV loop by snaring. Then you can see that catheter is exchanged with the 5 French longer catheter. Then exchange with the harder wire, and O3 wire the extra support. Then again dilate the IS area, then followed by again there was issue, but here it is very close to the metal wall. So you can both, and you can catch the wire and you can push. So that give an extra push on that. So again you can see there are a lot of difficulty on that, even with the transapical part, because of the huge LA and displaced LV geometry and the LA. ultimately we got it. And it is almost like 75 rather than 80, almost 3/4, and dilated that. Finally, we got it. And it is, we can call it rather than 80:20, it is 70:30. And this is the final result, and again inflated. And this is the result without MR. And so take a message, AV loop and hybrid approach both are good alternative procedure technique in selected cases. CT help in IS puncture, and also take surgical exposure LV apex in relation to the rib space made easier during the second case. And T-guided IS puncture is a crucial step in TMVR. Thank you.
Very challenging cases, Ashraf. In the first case, one question, whether would you have tried another septal puncture?
Yeah, basically we had tried three times. Second time also we punctured. When we confirmed it is the correct location, it's all because of some geometrical anomaly. Because that patient also, the LA is dilated.
And
Basically,
case,
if you see the anatomy, this is for the juniors level, the left atrium usually dilate posteriorly, and it stop at the spine, and also dilate upwards and stop at the bronchus. Then it comes toward the right atrial border, and that's why we don't know which phase we are doing the intervention. Probably if it's the later space, the dilatation may be either middle direction or posterior, we don't know. So we are doing in the intermediate phase of the LA enlargement.
in the second anatomy, I think, if such a case comes again, would you consider primarily a transapical approach to assist and
Definitely. Because if you take the series totally in the US and all, I've gone through that last mitral intervention series. What are majority of they tried with the transapical. The series are good with the transapical route. Then because those time that was the self-expandable and the Medtronic part. The studies now came with the sapien. Now they are trying with the transeptal. Now the transeptal data is there.
And they're trying many percutaneous transapical also, and they're designing devices to close the percutaneous.
Because their surgical hand is better than ours, so that will be easy. And Ashish, one more thing, rather than because huge LA, you can make it even lateral also.
One comment, because from Dr. George's experience, we know that in a hugely dilated LA, it is easier to access the mitral valve from the transjugular. So whether that is an option when you have a huge LA like this, because you don't have the difficulties of having a loop and then taking the valve over the loop.
But the puncture will be a little more technically demanding, right?
Not really, because you do it in the levo phase, an injection, and then a levo phase, you puncture, and it's far easier than coming from the transfemoral approach.
Sir, when you
pushability, that like what we are doing for the PTMC.
So when you're creating an AV loop, would you require a Landaquist itself? Because
No.
should be a routine.
We tried with the Terumo hardware, then 035 double length. Still, it is not good. Then lastly, we know that Landaquist, if you take the Landaquist, as you are actually cutting the LVOT, that is the iotomitral curtain. And actually speaking, in a patient with TMV case, if there is septal hypertrophy, the one method is you are slicing the anterior mitral leaflet technique is there. Just like that, if you are going with that, there will be chance of cutting that iotomitral curtain and all complications. So we are little bit judicious in that area. So we took all the steps.
So the final, the AV loop was created with a routine 035.
No, Landaquist only.
With Landaquist.
No, because nothing is going on. We tried 2 punctures and everything. What, sir? Yeah. But actually, see, sir, Safari, we took the extra short. That is the 2.9 into 3.3, the loop, not the routine, the tower Safari. And the Lunderquist, the initial part will be softer. And whatever going initially will be so, but when you go proximally it will be harder. It may cut the alveoli.
I mean, it is true, but I think as a point of learning, people should not be doing.
No, never. It is an extreme of cases. And basically, this patient is to my neighbor only, and the son is a policeman. Everything is there.
Ashish, the septum enlarges inferiorly. So people who are doing with large LAs, both mitral valvotomy or otherwise, the septum enlarges in rightwards, inferiorly,
Inferior.
and posteriorly.
But issue is
think,
no sir.
a
Issue
Tudor approach would be good. The septum, in fact, will be much inferiorly placed. Yeah, it's convex all right.
but
Because
Ashish
we have
issue
had a huge
Ashish issue
LA
is unlike
transeptal puncture. We have always had inferior punctures.
Ashish depends on the your whether RA enlarged or not. If the normal RA, you are making risk of stitch phenomenon because that initial part septum may not be there. Because LA is too much dilated, RA is small. So depends on whether biatal enlargement or only LA enlargement or one is the disproportional LR, the septal lie may be different. So
Okay. Very challenging cases,
Thank you.
Ashraf. Thank you very
Thank
much and congratulations. We'll move to the next presentation, coronary protection in TAVI by Dr. Vishnu and Dr. Bijala.
Good evening all. I am going to present a case of coronary protection in TAVI. Actually, I am presenting 3 cases combined. First case is a 78-year-old female, diabetic, dyslipidemic and hypertensive, severe symptomatic aortic stenosis with mild AR. She was having a paroxysmal AFib also. She is anti-HCV positive. On 3-dimensional analysis, we can see that her perimeter derived. Can I get a point? I need a pointer. Yeah. The perimeter derived annulus is 23 and area derived annulus is 22.4. And we can see that an LCA height here in the left side, it is a 6.8 and the right side is 11.9. And the sinus of valsalva diameters, we can see that it is approximately left 29 and the right 27. And this CT analysis also is showing that left side it is 11.9 and the right side it is comes under 6.8. So we started the procedure and we were anticipating any coronary obstruction after valve deployment. So initially we had we kept a guiding catheter on the left LCA and with a wire in the left coronary system, and we had balloon dilated and see how the calcium will how the coronary will respond with that calcium in the aortic valve. So the next step we can see that. So that we had kept the valve across the annulus and we had deployed the valve, and still that guiding catheter with the gate extension and that wire is across the coronaries. And here we can see that after removing that gate extension and guiding catheters, the stent is there, and we had assessed the patency of the left coronary system. And in the different angulations, we had seen that, and the left coronary is patent. So we had removed the left wire and the guiding gate extension, and we had taken a non-cannulated shoots, and then pictorial angiogram showing the patent left system. So come to the next case. 81-year-old male with bicuspid aortic valve, severe symptomatic aortic stenosis with 2 heart failure admissions, and EF was 45%. This case also you can see that perimeter derived annulus was 26.5 and area derived 25, and the left side coronary height was bit in the borderline range. It was 10.8. In the right side it was 20.6. Right was not okay. Left was little borderline. So the bicuspid aortic valve we can see with the severe calcification. We cross the valve. We can see in the angiography itself the severe annular calcification. That calcium was the worrying thing in this case. Initially, we had done the balloon dilatation. We had kept a guiding catheter near to the coronaries, and we had taken and we had seen that coronary how the calcium will the calcium obstruct that area. So in the first angiogram, we can see that since it is getting overlapped there, we were not able to see the coronary ostium properly. So we changed the angulation in the next one, and we done a balloon dilatation and saw how it is responding. And the coronary ostium is looking okay in this case. So we proceeded with implantation after putting a wire. Here we didn't kept a gate extension catheter or stent. We had put a wire across the left system, and we had placed the valve, and then we had inflated the valve. During inflation also, we can see that when we are injecting in the left system, the left coronaries are flowing well. And so after deployment, actually with the wire, we had taken one more shoot and we had made sure that the coronaries are flowing. After that, we had removed the wire and took the shoot. And this showing the coronaries are flowing very well. And then pigtail angioiotogram is showing coronaries flowing well and with no AR or perivalvular leak. So the third case, it was a 62-year-old female. This one is actually a valve-in-valve case. It is a bicuspid aortic valve, previously surgical AVR done with a Magna Ease, and she was underwent a SVG graft to LAD during that time. So now she presented with a degenerated processes with the aortic valve gradient 95 by 15, 98 by 50 with a good biomedical function. It was intermediate STS score. Here we can see that annulus is approximately 18 and 17, and the coronaries in the left it is 4.1 and the right is 10, and the sinus of valsalva is also in the borderline range. The diameter we can see it is 27, 28 in the left and right. And here in the when valve in valve we are doing, we have to look for this valve to coronary distance also. Here we can see that in the valve to coronary distance is 3 in the left system and 4.5 in the right system. So in the left system it was with borderline range. So we see first we went ahead with non-coronary shoot, non-cannulated shoot in the left system. And here we can see that LCA is continuing as circumflex. LAD is occluded, but SVG is taking care of that part. So we wired the left system. So then right side RCA shoot we are taken and RC is also wired. And we kept a wire, then stent with the help of a gate extension catheter. In the left and right, we can see that a stent is placed across. Because in this case, we were expecting that there is a high chance for coronary obstruction. So we can see that placing the self-expanding valve across 23 millimeter evolute. So we had deployed the valve. So during the deployment, we were checking the left system, how it is behaving, and the right system next. We can see that both the coronaries are flowing well. So the next we had removed. So next we had post-dilated that part because a paravalvular leak was there. Then we can see that the coronaries are flowing well. So we removed the wire and stent, and the final aortogram is showing nicely flowing coronaries without any obstruction. So the take-home message is optimal CT evaluation and preparation is a key for a procedure success. Anticipate coronary occlusion in cases of low coronary heights, small sinusovalvular diameters, and heavily calcified leaflets. And preemptive coronary protection with a guide wire and undeployed balloon or stent with a guide extension catheter can reduce the risk of the procedure. Thank you.
Great cases, Vishnu. Good that you had no complications and everything was well anticipated. And the next presentation would be by Saurabh, Cobra Head Deformity.
Good evening, all respected chairpersons. My case is not that much complex, but we found with dealing the case actually. This is a AST device closure. So my case is a 11-year-old female patient diagnosed with ostium secundum AST. The size was around 18 millimeter with mild pH and RA-RV were dilated. So on echo, the IV serum and aortic rim were deficient. So we planned for the attempt of the device closure. As you can see, the TE images are there. That aortic rim is deficient, but the post rim was sufficient that we thought that it might hold the device properly. So the length of the defect was around 18 millimeter. As you can see here, IVC rim is very flail and deficient here. The measurement was around 3 millimeter only. So we planned for the device closure, but initially we found difficulty in engaging pulmonary vein. It was slightly abnormal because it normally what we find that vein is normally outside the cardiac styloid, but it was coming so much entirely within the cardiac styloid. So we tried to attempt the device closure with this point only. But what happened, that device was during tracking, it was deforming into cobra head. So we planned with again left upper pulmonary vein. Again, that it was very difficult in engaging and slightly tortuous course also. So again on the tracking, again with device was going into same cobra head deformity. So that again with manipulation, it was not gaining its original shape. So we tried with this only two to three times at least actually. Then we went up to support from the right upper pulmonary vein actually. Again, the same result. The device was again gaining that cobra head and not coming into an original shape, even with significant manipulation. So this was a device shape. So in ex vivo, actually, initially, with slight manipulation also, we were able to gain its original shape. So we thought that we'll change the device. I think we thought that device might be stiffer to accommodate. So we went with another device, another space, same right side upper pulmonary vein. This time we deployed slightly distally and with some maneuver and tugging actually. So we were used to get the normal shape of the device. We were able to get it. This why it was no cobra head, and finally it was holding the device nicely. So tugging was checked, device was holding nicely. On echo also, we checked all the parameters, so it was holding nicely only without any impingement. And finally, device was deployed. So what happened initially, this is a cobra-like configuration of the device. It is a rare but known complication of AST device closure. Normally occurring to 0 to 3% of published series, but nowadays it is quite rare nowadays because of advancement in device production and all. So this distortion range from slight bulge to the cobra-like position. So what are the causes? So normally in the literature, it is described as a very large atrial septal defect with absent aortic rim. Sometimes presence of a manufacturing defect. Sometimes we excessively distal release of the device. When we device is been released very distally, like in left atrium, lateral appendage or pulmonary vein orifice, it can give rise to this kind of deformity. Even abnormal anatomy of left atrium, left atrial appendage or pulmonary vein. And sometimes a device size, device and a sheath size mismatch, the position of device within the sheath may give rise to this kind of complication. So this pulmonary vein actually very quite abnormal anatomy actually gave rise to so much problem and gave rise to cobra head deformity in our cases. So learning points, knowing the anatomy of the patient is very important, and choosing the correct device and the proper manipulation can avoid this kind of deformity. Thank you.
So which was the device make? Was it Amplats or something else?
First was Amplats, sir, actually.
And
That
what was its device size and what was the sheath size?
22 size actually, sir.
And what was the sheath size?
10, sir, 10 French actually.
Okay.
Yes,
What is the recommended sheath for 22?
Same only, sir, 10 only, sir.
Sometimes this cobra head device deformity happens when you put a bigger sheath.
Bigger sheath is,
Yeah,
yes, sir.
suppose you set 12 French sheath and put a 22 device, whereas 10 is only required. That sometimes forms this cobra head. So
Yes,
you
sir.
should not oversize the sheath. That is one.
Vigilant both the oversize and the correct size. For example, if you are making 10 French, and exactly 10 French also issue, because when you are pushing, there will be nitinol crossover. And if it is, usually we will, the extra push causes the nitinol crossover. Second thing is the larger, as you said, when you're pushing, again you have extra space that can cause infolding of the nitinol. That will be permanent and you should not reuse it. So probably, and turn also, because habit of the teaching is you have to in the sheath itself you have to show that you are in the control. So that overuse of
This oversizing is an important
Yeah,
reason for
definitely.
cobra
But,
head
yeah.
deformity.
oversize.
So if
But
it is 10 French,
basically-
you should use only 10 French. If the recommended is 10
No,
French, you should use only 10
the
French.
issue is only the nitinol crossover, that's all. And in the newer generation device, that area is complete because of the nickel, they are making extra coating. That may prevent the nitinol crossover. Probably that may be the one manufacturing defect for the Amblats series.
In this case, pulmonary vein is
You
smaller.
should not use the same device because of the crossover, already crossover. No, should not. Once cobra head occurs, you should not use that.
And pulmonary vein size, anomalous pulmonary vein and pulmonary vein size, left side is a little smaller.
How does it relate to cobra head? I don't know.
For example, LA appendage. People have habit of putting the LA appendage or water small size. That make a shape of that. That will change the geometry of the intranitinol framework. So in this case, definitely the abnormal anatomy made that issue.
Next is TAVI in bicuspid hypotension after deployment, embracing complication as part of journey.
Good evening, respected teachers, friends.
My patient is 74 years who's been diagnosed to have moderate aortic stenosis. He was on follow-up till 2014 and then landed up with ACS end STEMI, and he was angiogram showed double vessel disease. We stented him, and at the time echo showed severe calcific aortic stenosis with a mean gradient of 51 and mild left ventricular dysfunction. After stabilization of coronary artery disease, he was planned for TAVR. Now you can see that it was a bicuspid valve with a annulus of around 25. Other dimensions, sinuses were roomy. There was certain glitches in the anatomy. You can see there was a nodular calcium here. Now, this was the problem. You can see, if you see here, this is a bicuspid with a severely calcified raphe between the left and right. And to add the problem, there was another nodular calcium at the annulus level. So here, what will happen when you deploy a valve is it will refuse, if this will refuse to budge, and all the pressure while we deploy the valve will be on the non-coronary cusp, which is close to our conduction system, and the predicted pacemaker rate is high in this subset. So we chose an octacore considering these to prevent PVL with a less of a oversize. So a 26 millimeter my valve was chosen. The valve was closed. The sheath was inserted. The pre-dilated with a 2040 and 26 millimeter octacore with 1 ml less was positioned across. When I was positioning and whenever I was doing fast pacing, he was severely hypotensive and was restless. Now you can see when I was deploying, patient was actually moving a lot. But then I managed to deploy. Immediately after that, he went into shock. His BP was rapidly falling. So every system was alerted. We got the echo machine and we saw that there is something developing here. You can see the pericardial collection, and inotropic support was escalated. And now I have to figure out what exactly is happening. There was tachycardia, hypotension, transthoracic echo is showing this. So first question, that because it was severely calcific and we have put a balloon expandable valve, whether it is an annular rupture. So the first thing I did was a iotogram, which showed both coronary arteries are filling and there is no annular rupture. And meanwhile, my co-operator punctured the pericardium and put another pigtail here and started pericardiocentesis and autotransfusion. The protamine was reversed. He was intubated, a TE was in place. And after the hemodynamics was stable, I did an LV angiogram just to see whether there is an LV perforation, but that was also ruled out. So most of the time, this happens because of the pacing wire. So immediately after so mostly the pacing wire induced perf was considered, and continuous pericardial aspiration was done. And now we noticed through all this time he was under pacemaker. He was in complete heart block. So we cannot move the pacing wire at all. Then what we did was we put a permanent pacemaker with a VVI lead screwed into the septum. And after that, and reversal of everything, we removed carefully the temporary pacemaker, and probably we could see a small rent in the small thin part of the RV. We decided we will conservatively treat, and there was already a blood clot forming in with mild pericardial collection. And we transferred the patient to ICU and decided to monitor. Luckily, in 8 hours, the aspirate came down, and there was no further collection, and he improved over 12 hours, and he was extubated. The next day, the echo showed no significant gradient, and there was hardly any leak, PVL, and there was mild pericardial collection. And 3 days later, he could go home. So a shock immediately after valve deployment, that is something that give an adrenaline surge to when you do TAVI. First thing and the most common thing is a tamponade because of either wire or pacing lead. The most dreaded complication would be an aortic rupture. That is a time when you need to alert your surgical team and cardiothoracic OT. Coronary occlusion, most of the time you can predict with the CT, but then always should be looked when you do an aortogram. Vascular complication can be a cause for shock. Then severe valvular, mitral, or aortic regurgitation can cause rarely severe shock, and very rarely in those severely concentric hypertrophied ventricle, the suicide left ventricle, immediately after deploying and changing the hemodynamics, they may go into shock, which has to be dealt with totally different mechanism. So to take, as a take-home message, technically, TAVI is feasible in bicuspid anatomy if you choose the patients carefully. The intensity of calcium at RAFE is, especially if it is extending into the LVOT, is actually a predictor for pacemaker. So we have to anticipate complete heart block in such patients. If there is a hypotension, quickly screen for most important complications like aortic leak, LV leak immediately. Alert your surgical team and perform prompt pericardiocentesis if there is a pericardial collection, and do water transfusion, reverse the heparin, and then we can delineate most of the time the cause for hypotension and can be treated safely. Thank you.
Okay, Shavik. Lucky that you could manage it by yourself. You didn't need a surgeon.
Yeah.
And but I saw you putting in a balloon tip pacing, but even that,
Yes, even then.
it.
So I was looking back again and again what happened, because this was, I assume that when I was doing pre-dilatation, with fast pacing, he was going to, BP was going till to 40 millimeters, and he was so restless at that time. He was not tolerating that. So I should have deepened the anesthesia at that time. He was on a light conscious sedation. So that's a learning point that I had.
It should be a very good case. Contrary to the popular belief, we say that the TP has to remove the surgical presence. But more than 90% case, nothing will happen. Slowly take the pacemaker after 2-3 days. By the time clot may form as you did.
Yeah.
And I think all these cases, even we are not diagnosed as a pacemaker. So a bit of taking at least CT follow-up before discharge is good, especially in a bicuspid with such a bad calcification in that area. Because intolerant aortic rupture, we cannot diagnose even the aortogram rather than the CT. But Mathematics, very good case, excellent demonstration of how to save a patient with the pericardial terminate. My question is, suppose this aortic cannular rupture occurs in such cases. Do you think the patient will survive? Or what is the outcome of such patients? Any cases survived on the table?
Yes, on table, most of the time they have to go for surgery.
Surgery is the one thing.
Surgery is one thing.
And till the time, how do you manage that aortic rupture and rupture?
I have seen read case reports of putting plugs in the leak, 1 or 2 cases, then putting another valve, but then all with very limited survival. But most of the time it is the surgeon who saves us. So a severe shock immediately after deployment, we have to have the OT ready.
And one thing is, why do you think that is a pacemaker lead is a reason? Because we use a lot of wires. That also can produce perforation.
Exactly. That was my sequential analysis. First one was aortogram. Then I did an LV aortogram, whether it is a LV wire-induced LV perforation. It was ruled out. Then it was the only reason, because we have a tamponade. Most of the time in annular rupture, there won't be a tamponade. Pericardium will not be involved. It will be more mediastinal. 180 for pre-dilatation. 180, yeah. Balloon expandable valve, so 180.
Due to lack of time, shall we move to next case?
No, most of the time, when we do fast pacing, the BP goes down to 80, 70 and all. 40 and prolonged at 40, he was very restless. Probably he flexed his limb. Left limb was the one which was having the pacemaker limb, and it perforated.
Thanks, Traffic.
Thank you.
Next is Dr. Paul Thomas, TAVR in a complex subset.
Good evening, everyone. From General Hospital Ernakulam, we are presenting a case of TAVR complex upset, which was proctored by Dr. Ashish sir. And this was a 60-year-old male with recent onset heart failure, class 2 to class 3 to class 4, who was admitted with chest pain. His echo showed severe LV dysfunction, and still the aortic max PG was 74 and the mean PG was 42. The ECG showed bifascicular block, and we took the patient for a coronary angio, which showed a borderline lesion in the LED. He was anticoagulated because he had a LV apical clot. And after medical stabilization, we had a heart team meet regarding the management, because one of the problems was he was having, because of the religious conviction, he won't accept blood or any blood product. And so in this situation, surgery would be the option with priming. That has to be an elective procedure, and you may have to use cell saver. We had a thorough discussion, and after that, the patient and even our surgical team said there was a very high surgical risk, and patient had multiple opinions and finally opted for a TAVI. So we took the CT and showed a type O bicuspid aortic valve, calcium score of 2,887, and significant calcium in the CT aortogram. The coronary heights, RCA was RCA height was 28.3 and the LCA was 19.6. The diameters, the perimeter derived diameter was 29. And here the challenges were the patient was having severe LV dysfunction and severely symptomatic. At times he was in cardiogenic shock. Recent LV apical clot that was resolved by a 2D echo. Borderline renal functions, very high calcium score, bifascicular block, and above all, he won't take any blood transfusions. So we planned the TAVR, and under conscious sedation, and all the punctures, even the venous puncture was taken under ultrasound guidance because we didn't want to lose any blood. The 5 French balloon tip TPA was put, pigtail 5 French in the aortic sinus, and 2 proglides were deployed. And the AR could not support entry to the LV, and we had to use a AL1. And after that, it was exchanged for a Lundakus wire. A 14 French Python sheath was introduced, and a 25 millimeter mammoth balloon was dilated at 25 cc. Just after the dilatation, we found that the balloon had ruptured. So here we have another problem. Retrieving the mammoth into the python was a problem. It was not easy, and we tried inflating it again and deflating it, but the balloon was not going into the sheath. So when it was pulling the pigtail catheter, so we had no other option. Had to take out the mammoth as well as the python, and the sheath was dissected and seen torn. The distal part of the balloon was deflated. Quickly we exchanged the system and deployed the valve. The valve was not crossing the aortic valve. My valve was not crossing the aortic valve because of a bit of a horizontal position. So we used a body wire, Amblat's super stiff wire, and somehow it crossed with the LV, and the valve was deployed. And after deployment, the patient went into shock and had a pericardial effusion as in the last case by Shafiq sir. And here the ghastly image was that the patient was having an aortic perforation. And significant pericardial effusion. And we tried to plug the rent in the aorta. A thermo wire was passed into the wire and into the rent. Everything was set for pericardial aspiration. Surgeon was called for, but surgeon was ready to take, but the patient is not ready to take any blood transfusion. So here that door is also closed. And while we are attempting to plug the red, the patient told that, the bystander, the relatives told that, come what may, we won't take blood. And now they were very much reliant on the power of prayer. Now we were the people who were praying. And it happened so that somehow the rain got closed off. It was the thermowire was kept in the vent. Plug was arranged, but at that time patient, but still the patient was having severe hypotension. In between he had AV block, junction rhythm. We checked the RCA. There was proximal spasm and RCA was engaged and given NTG, but spasm relieved a bit, but still some extensive combustion also was doubted. Then we checked for the left main. There was showing some left main ostial compromise. So left main was engaged with the JL, and that was 4 into 16 stent was deployed and post dilated. Finally, we found that there was there was no significant AR, there was no gradient. Then we took the final shot, and this was a femoral artery. It was beyond redemption, so surgeon has to be called upon. And because the mammoth had done that damage to the femoral artery, and as well as a proglide, we had to put a graft in the femorals. Patient was on triple inotropes. Serial echo showed no tamponade, but we were reluctant to aspirate. Thought of IABP, but that also may increase the perforation. That may sometimes reopen the perforation. The HB was dropping from the ABG, it was 7.5 and 6.4. Patient was having severe lactic acidosis. Still, they won't accept blood. And only thing that was left, that because patient was continuing to be in junction rhythm, we put a dual chamber temporary pacing, and after a few runs of atrial pacing, patient became the PR interval became better, and the hypertension was relieved a bit. Okay, and then overnight the patient was having severe hypertension, still holding with triple inotropes. And AKA developed early DIC, ischemic hepatitis. The acidosis improved by day to morning. The only thing that hasn't happened was the complete heart block, which we expected prior to procedure, but that hasn't happened till now. Day 3, the renal function improved. Now the INR improved because the patient was ready to accept cryoprecipitate, and inotropes tapered off. Day 4, patient developed atrial flutter. Day 5, significant pause. We tried dopamine, and isoprenoid just to avoid a pacemaker. Day 6, the ECG was normal. Day 7, again the patient developed complete heart block. So we had to put in a left bundle pacing. Dual chamber left bundle pacing was also done. We got a reasonable QRS. Incidentally, our previous TAVI patient also had to undergo a left bundle pacing. And after that, patient has now recovered. Patient has a little bit of trivial paravalvular leaks, but still is recovering, and is ambulated and has been discharged. So this patient had a high calcium subscore, so calcium score, supraannular calcium, difficulty in crossing the aorta, aortic valve balloon rupture, femoral artery avulsion, aortic perforation, pericardial effusion, RC ischemia, LMCO OC involvement, severe LV dysfunction, LV clot, bifascicular block, flutter because of possible pericardial irritation, and at last ended up in a dual chamber permanent pacemaker, left bundle pacing. Thank you.
All possible complication in one case. I must congratulate the operators. Yeah. I think, what do you think the cause of actually perforation? Is it the sizing? Is it the?
It was a bicuspid aortic valve and severe calcium.
Because I remember reading a case report where they put a self-expanding valve when tough aorta is navigated through the outer curve. We used to push, right? That push actually sometimes causes this. So here, this was retroflex completely.
I think whatever that
if it's aorta RV fistula, the classical angio picture, the complications is the aorta RV fistula. And since the patient has got Icck, we can't send for the CT angio. Second thing is the patient has high grade AV block, even beyond 72 hours, high chance of more than 90% patient may require the pacemaker. So even the third day itself, since the patient has the early sepsis, no issue. So if you take the new onset left bundle branch block and high grade AV block beyond 72 hours invariably. Because what are happen, new onset LBBB or high grade AV block beyond 72 hours, 90% patient may require the pacemaker. And beyond that, after 3-4 days, the chance is very, very less.
But we had it in the 6th day, sir.
No, by looking at the staining method, yeah. Because the staining and
No, sir, it was
May the
persistent
operator
staining.
say-
It was a persistent staining, sir.
no.
See, I think this is an annular rupture rather than, it is a contained annular rupture. It is not an aortic run.
No, the extension
See,
with the
and
RV.
This is the.
Because unless has to go somewhere, no? Your track. Unless, see, if you have annular
No,
rupture,
you can
you can
open
go
the
into the
RV also.
pericardium, actually the medial side, or I mean, the lateral side, mitral part, and the RV part, usually the RV part.
Yeah, no, you can open to the RV. We had a
But
patient who had an annular rupture,
this is the
opened to the RV.
9 to 10 o'clock portion, the staining is occurring.
The other thing is that, see, this patient had a very big, huge amount of calcium. So this is a expected or, likely complication.
Yes.
But the fact that it showed right bundle, left axis and prolonged PR, I think that is a trifascicular block going to requiring a pacemaker.
Yes, sir. But that was on the same. Oh, yes, sir.
It's a trifascicular.
Yes, sir.
Thank
Yes,
you.
sir.
Thank you, Dr. Paul Thomas. Maybe in this particular patient, self-explain, you have smaller valve would have been better, smaller system, where the patient cannot take a transfusion. Maybe it is a smaller system, this complication may not have happened. Okay, come to next patient. Next case, that is last case in this session. That's by Dr. Praveen Velappan, near zero contrast tower.
Good evening, chairpersons, teachers and friends. Today we will be presenting a case of TAVR done under local anesthesia, conscious sedation, and using very low contrast volume. The 79-year-old gentleman who had a prior history of PCI 20 years back, and he is a diabetic, comorbidities, systemic hypertension, CKD, and recently diagnosed to have severe aortic stenosis. And his hemoglobin was 9.4, creat was 4.9. And his echo actually showed moderate LV dysfunction, severe aortic stenosis, mild AR, and a low moderate MR. And the CT annulus area derived was 21, and reasonable coronary height was there. So after the CT, the patient came back anuric, and we had to take nephro support, and he was started on dialysis. So since the patient was in AKI, and since this was a planned procedure, even anesthesia department also was not willing to support. And we were also very happy. We thought this is the ideal time to discuss with the patient, tell them that he will have to be on medical management until his kidney improves, which will never improve. So before discussing with the relatives, unfortunately, Ashish sir had already boarded his train. And so my HOD, we called Ashish sir, telling him, about to tell him to go back if he was in the railway station. But unfortunately, he had reached Thrissur by that time. Then, with his support, we decided to go ahead. And then we discussed with the relatives. We told them that this is the situation. He will have to be on long-term dialysis. And we are trying to go ahead with this procedure with the minimum amount of contrast possible. So after that, these are all the normal, everything else was fine for a trans aortic valve replacement. And considering the patient's general condition, we decided to perform the procedure under local anesthesia with conscious sedation. And the patient was monitored closely and he maintained saturation throughout the procedure with oxygen. So we got the usual access and a single proglide device was inserted and a balloon tip TPA also was inserted. And the first step, we crossed the aortic valve, then put in the 6 French pigtail catheter and assess the gradient, which was significant across the aortic valve. Then the Safari extra small curve wire was introduced into the LV. And then we needed to avoid contrast. So in the coplanar view, we needed to deploy the valve without taking any injections. So we decided to keep two pigtails, one in the non-coronary cusp and another in the left coronary cusp. But it was not possible to position the pigtail in the left coronary cusp. So we used the Amplatz catheter for the same. And this is introduction of the Python sheath. And this is the coplanar view where you can see the Amplatz AL1 in the left coronary sinus and the pigtail in the NCC. And with the help of this, we brought the valve up and positioned it. So while positioning, the valve bumped the AV node, followed by complete heart block, and the pacing started. And here we injected 4 ml of contrast, which showed that the valve position was away from the coronary ostia, left coronary ostia, and there was apparently no significant disease in the left system, because in the initial CT pre-procedure, we had asked for a CT angio also, but we couldn't make any clear assumptions because of heavy calcification of the coronaries. So after this, the valve was deployed without any rapid pacing, because at that time the patient's BP was only 50/30. And the post procedure, the gradient was came down. And before coming out, we did a right coronary common iliac artery angiogram with 4 ml contrast to confirm patency of the right iliofemoral system. And the BP improved after valve deployment. Heparinization was reversed, and the patient recovered from complete heart block after a few hours, following which the TP was removed. So these learning points were for us. So we learned that we can do a TAVI with very low contrast. And if we had a peripheral IVUS, probably we could have avoided the last 4 ml contrast also. And if the patient is very sick, like in an acute kidney injury on dialysis and all, we can even avoid a proper anesthesia and go with local anesthesia and do it. Thank you.
Very nice case. You had a CT as a sizing for sizing, and you all had all the details.
Yeah, initially when we planned for the CT, we thought we'll take because we had a history of PCA 20 years back, we thought we'll take a CT coronary angiogram also. So probably the amount of dye put him into anuria. And
yeah. Suppose if the creatinine is high already and you cannot do a CT angiogram, then the way
there are reports where gadolinium free MR angio was done, and then with that assessment was done.
So the sizing can be done by a combination of a 3D TE, then a non-contrast CT with the markers of calcium, and non-contrast MRI. So we can have a rough idea of the annulus size. You can use Dopplers for the vascular assessment of the axis. And then during deployment, as you said, 2 pigtails. So the normal pigtail will not go. So if you want to go to the left, you need an angled pigtail or like a AL1 catheter which can be parked. So you can avoid injections in between, and preferably a TE during the procedure also, so that you can have an echo guidance during the procedure. And preferably a self-expanding valve where you have a little margin of error in sizing. That's the tips for.
I think TE should have been used, and that pulse pressure looked very wide, and that end diastolic, the difference between the aortic diastolic pressure and the LVDP was quite low. Was there AR?
Yeah, there was air. Mild air only was.
Only mild.
Basically, Shafiq said right. But if you take the peripheral instead of Doppler, you can the CT angio almost carbon dioxide angiogram almost equal to CT angiogram, all the infra-abdominal iotogram, and CMR is almost correlate with the your annulus and all, and the non-contrast CT is also okay. So CMR always available in non-contrast CT, and if at all carbon dioxide angiogram is selected center, that will be almost equal to our CT angio. In near future it may come without CT.
Yeah.
Post procedure there was no much rise in the creatinine, and he was continued on dialysis and his output improved, because for the procedure we hardly used any dye. The only dye used was for a pre-procedure CT.
Yeah. Thank you. Thank you so much. Excellent cases and great discussion. We had a nice session, and with this, we conclude the session. Thank you. Thank you so much.
Thank you, Anantal. So we are moving on to the last discussion and session of this day, structural interventions, session 2. Let me request the chairpersons, Dr. Arun Gopalakrishnan, Dr. Edwin Francis, Dr. Praveen SV, and Dr. Rajiv C to come forward to the dais. Please occupy the chairs.
Let's start with the first case, Al-Kappa interventional treatment, Arun Gopi.
Respected Chair, this will be something different. So when Dr. Pratap says lifelong journey of opening up CTOs, here we are creating a CTO to probably treat a disease. So the story is of a middle-aged person with effort dyspnea for worsening for over the last 6 months or so. ECG showing some evidence of lateral wall ischemia. This is the echo shows. Echo shows RW in the LAD territory. Normal LV function, mild MR. You see a dilated RCA, and there's a shunt at the level of PA. We get a CT done, which confirms our diagnosis is an Al-Kappa with well-developed collaterals, dilated LV with reversible perfusion defect in the LAD and LCX territory, no definite scar. We send her for surgery, and she again comes back once in between with a myocardial perfusion scan. So she actually didn't go to the surgeon. She kept on medical therapy, but the perfusion scan was again alarming, significantly dilated left ventricular chamber with about 20% perfusion defect. We again insisted on surgery to her. She went back. After some months, I get a call from the surgeon saying that you need to do something for this. The patient had actually gone to 3 surgical centers. Everybody offered surgery, but she was not willing because her close relative died post-cardiac surgery. So we have a middle-aged lady with symptomatic Al-Kappa with ischemia demonstrated on perfusion scan, 20% of myocardium showing reversible perfusion defect, and bystander just not willing for surgery, and they want a percutaneous treatment. So just a recap about Al-Kappa: 90% die in infancy. People who survive to adult have extensive collaterals, but they survive at the cost of coronary steel. So there are reports of angina, dyspnea, and sudden deaths due to coronary steel. In childhood, coronary translocation is a treatment, but in adults, people have tried surgical ligation of LMCA and giving a graft. Because of the size mismatch, always it's an SVG to LAD, and there's currently evidence lacking to say that this additional venous grafts give some advantage. So almost 1/4 of surgeons actually practice isolated LMCA ligation. So we thought, why don't we just replicate percutaneously and isolated LMCA ligation via device closure? We looked at the literature. There's one case report by Shivkumar, who has done a device closure of Al-Kappa with a muscular VSD device. So we took a clue from that and we took her to the lab. So first we demonstrate the Al-Kappa. This is the RC injection showing the Al-Kappa. We wanted to see where the LMCA gets into the pulmonary artery. It's just above the pulmonary valve. On the anterolateral area, the challenge was the sharp inferior angulation. You can see there's a sharp inferior angulation in the RO view, and the ostium measures about 10 mm on the angio, 13 mm on the CT. So we take her with an intention to close the Al-Kappa. So right femoral axis, 8 French sheath. Right arterial axis, 7 French guide taken into JR7 French taken into the RCA to demonstrate the Al-Kappa well and see the origin of the LMCA. And we cannulate we had some difficulty cannulating the Al-Kappa because of its location in the PA, and we were able to cannulate with the JR. And then on a Teflon, we exchange it to a JR7 French, JR8 French guide. The sharp inferior angulation was quite challenging. We wanted to deeply intubate and try to track, like Shukumar had reported, using a mother and child approach, try to track some sheath in. But that sharp inferior angulation, we failed to track anything down. So we put in Teflon inside the coronary. We put in a Grand Slam and a Teflon inside the coronary. None of these things helped us. We put in, through the 8 French guide, we put in a Teflon, we put in 2 wires, took 2 Grand Slams down, anchored balloons, and then finally, with a lot of difficulty, we were able to negotiate that curve. So then we thought what device to use. We thought of using this made in India. This is from Nageshwar Rao, Konar MFO device, which has double-sided screw, which allows us to deploy it either using a retrograde or antegrade approach. It has a very good profile, very small profile, allows us to deliver through even guiding catheters, 4 to 7 French. Any guiding catheter can be used, and it has already been tested in multiple array of cardiac lesions with adequate safety, efficacy, and technical feasibility. So we thought of using this. So we have this 8 French guide in, and we are trying to track this device in, and finally we got the device in, and we deployed a Konar MFO 1412 and checked on the angio. We thought everything looked good. Mild intra-device leak was there, and we released the device. Oops, we look back. Have it released the device in the reverse way? Okay, so the story doesn't end there. So after some, sorry. I think we went back. Okay. So story doesn't end there. So the post-procedure patient has AF and the device embolizes, and we find the device in the left pulmonary artery. We capture it with a Mullen sheath, 9 French Mullen sheath, and we drag it down to the IVC. From there, we couldn't track it. Then we take a 16 French Cook sheath and retrieve the embolized device. So this time we thought we somehow would again try with the sheath. We wanted to pursue on device closure of the Al-Kappa. We tried to take 9 French sheath down. That acute angulation just couldn't allow us. So we repeated the whole procedure, and this time went really deep with the 8 French guide. And then through the 8 French guide, we deployed this the same device, the Konar MF 1412. It has an 18 mm disc, and this time it was positioned well, and everything looked good. And so this is what finally you could see, the Al-Kappa being closed with the Konar MF4 device, turning actually it into an LMCA CTO, reducing the coronary steal. You might feel that there's significant device leak, but on the echo, there's no significant device leak. And the EC, there was no EC changes post-procedure. Since we were doing something new, we followed up the patient. At 3 months, we call the patient back and we do a check angiogram. You can clearly see the device is fully endothelized. There's absolutely no leak across the device. And the collaterals have actually come down. The coronary steal definitely has come down. We do a CT to confirm what we have done is perfect. 3 months post-procedure, device is correct in position. The collaterals are still there, and there is no perfusion defect now. And the real proof of pudding comes from the perfusion scan follow-up at 3 months. LV looking normal size now, just perfusion defect coming down to 8% and significant improvement in the contractile function. So from Al-Kappa, we changed it to a LMCA CTO with the patient coming back from NYHA class 3 to NYHA class 1. EF improvement from 59% to 73%, dilated LV regressing down, 20% perfusion defect reduced to 6%, and MR regressing. So why this case was presented? Because only one case of Al-Kappa device closure is at least reported in the literature to our best of our knowledge. Adult Al-Kappa with heart failure not willing for surgery was the case. We closed with the made in India Konar MF4 device. There were many things happening. We placed it in the reverse way, which embolized, recaptured, and again positioned it back successfully. And we could prove the concept that on a follow-up perfusion scan, there is reversal of the perfusion defect, which was because of the coronary steal. The LV function actually improved, and there was reversal of the remodeling process that happened, and she's clinically doing well on follow-up.
Excellent case, Arun. Normally, it's surgery, especially if you have
always surgery.
Either it's a translocation or a baffle with a tachymetry, or in some cases, as you said, just dilatation, just ligation.
Always surgery. Better is PECUSHE. Arun would say the coronary translocation is the ideal one. Experienced surgeons have been doing it in the adult also, but inexperienced people generally ligate the LMCA and then put an SVG graft. But here the surgeon itself referred up for a device closure.
Unfortunately, in this case, there is not much of MR and LV dysfunction.
Yeah, sir, but there was 20% perfusion defect, but that reversed off. Even the MR was not that significant.
I don't what is the corner device, what is the interdisc distance?
4 mm.
4 mm. So probably while looking at that, it was more than 6 or so. So muscular device might be one option, or
We needed a larger. It was actually it was measuring 13 mm. We needed a larger thing, which needed a larger sheath.
No. Suppose the between that saccular part and the pulmonary end, the length of that segment, left main, is almost like 6 or 7, right?
We just need to plug the ostium.
Yeah.
We just need to
So
plug the
you-
ostium.
so you have a choice of, suppose smaller one, ADO2 can be used, or muscular device, or the corner, and also AVP3 also option. But because many of the time, when you go through when you see the pediatric cardiologist, the LPS nose and topostove is very, very tough. The angle is, two angles are there. So I have only one experience with the LPA balloon angioplasty, extremely tough. Even the cutting balloon also, it is not going. So making the device is by taking all the gadgets in the coronary, it's made simpler for you.
Yeah, because only guide we could take in, but with all the coronary gadgets, we were able to deep throat the guide. We couldn't take the sheath. That's a very sharp angulation. It was not as easy as we see to cannulate it.
One issue is, for the venous part, we can make it the larger 1.5 times of the that vein part. Here it's the venous part, pulmonary artery, and arterial part is the
Coronary
coronary.
part,
We don't know what is exactly the pathological inside, whether it's a venous end or the arterial. So you can always upsize the device more than or
This is
two
the
or three
largest,
times.
this is the largest M4 available.
Yeah.
M4 largest is
Yeah,
1420.
thank you.
See, I don't think you should plug the LMC arising from the PA. We have patients on follow-up, adults who do very well. In fact, and there's no reason why after you plug that the ischemia will come down. It's basically a collateral related ischemia. It'll be there. And did you calculate the shunt by any chance? Then, and the other problem is that you might have a possibility of having a thrombus extending into the left main itself. I think
Sir,
you
agree.
should leave
But
the
it can reduce
Al Kappa as a learning point.
Yeah, but there was perfusion defect which was demonstrated, and there is reduction of because of the coronary steel goes off.
Yeah.
The shunt comes down, the steel goes off. So that's the whole concept of even isolated coronary ligations.
But
Did you do the shunt?
I didn't just for basically the ischemia driven MR is the most determined part of the patient survival. I think
MR is just mild.
And one just for the fellows course, I just landed Trivandrum Medical MD Medicine. The first case in cardiology, there's MD Medicine. Second week was the Al Kappa, and Dr. Vijayaran sir said, you in the echo, you look at the RCA rather than left. It will be huge RCA. Then think of the possibility of Al Kappa. Don't look at the left. You look at the right. Just for the fellow course. And next is of course coronary cameral fistula. No.
Shunt calculation may not be helpful because it won't be that much of shunt for us
Yeah,
to-
but you can't relieve the ischemia because it is a total left main. You
Yeah,
have
but
collateral
your,
related ischemia
that
will
steel
persist.
that steel will be gone.
One question,
And
sir.
that is because of shunt.
One question is that the shunt has been reduced, all right. But what post-procedural thrombotic strategy would be? Because you have, sir, has, this strategy has only relieved the shunt,
Yes.
not necessarily the ischemia. And probably now that there is only one supply to the entire coronary system, what post-procedural anti-thrombotic strategy will be?
No, we just gave a single antiplatelet for we are planning a single antiplatelet for 6 months because it's from the RCA. RCA is huge. RCA is the one which is supplying, and that's disease free. It's a huge RCA which is disease free. We plugged only the LMCA. It's how we are actually creating an LMCA CTO, and then even if it embolizes, it won't come this way. All the collaterals are that way.
How long is Shiva's follow-up?
Now it is 6 months. The angio what I shot is at 3 months.
Not
She's
yet.
doing-
Shiva's case. Shivakumar.
Shuma's case is actually last year published actually.
Okay. Thank you. We'll go to the next. Trick valve, Deepak.
Good evening to all of you. Once again, thanking the organizers for the opportunity given. Well, this was a 76-year-old lady who had an ASD closure when she was 30 years ago. She had a complete heart block pacemaker implantation done in 2011, has moderate to severe mitral regurgitation for the last 10 years, severe tricuspid regurgitation on follow-up. She has recent worsening of symptoms. She has elevated GVP, cardiac cachexia, her renal function was deteriorating, creatinine was around 3. She has child C cardiac cirrhosis, massive ascites, multiple ascitic fluid tapping, low platelet count. So that was a case scenario wherein we were left to manage this particular patient. Till then, she was on follow-up for the last 10 years with medications. And this is how her ECG looked like. You could see that she is in atrial fibrillation and on paced rhythm. And the lower down image is just to show that she has a giant heart over there. That was the reason why it was shown there. This was echocardiographic images looking at the left side of the heart. The left ventricle was contracting while the left atrium was dilated. There was some amount of mitral valve prolapse with moderate to severe mitral regurgitation. Looking at the right ventricle, you could see in both the images the right ventricle is significantly dilated. In the four-chamber view again, you can see that both right atrium and right ventricle is grossly dilated, and there is torrential tricuspid regurgitation. And you could also see that the inferior vena cava is grossly dilated and the tricuspid regurgitation jet is going well into the inferior vena cava. That was the reason why she was developing cardiac cirrhosis and renal dysfunction. So we have a 76-year-old lady, moderate to severe mitral regurgitation, massive tricuspid regurgitation, cardiac cirrhosis, renal failure. How do you manage her? She is definitely a high-risk surgical candidate. So we're left with some conservative management for the mitral valve, and we decided on percutaneous management of the tricuspid valve. Well, regarding CAVI, that is cable valve implantation, we know that it's got two implants, one for the superior vena cava and one for the inferior vena cava. The superior vena cava has got a long skirt. This is a long skirt, basically in order to prevent the paravalvular leak. And the inferior vena cava portion, it has got only a very short skirt. Primarily, you wouldn't want to cage the hepatic inflow into the inferior vena cava. So the inferior vena cava device, it's got only a short skirt. So that is how both the devices would look like. The one for the upper one, superior vena cava and inferior vena cava. You have multiple sizes of trach valve. How do we evaluate this particular patient? Primarily, you need to have echo. A lot of parameters needs to be evaluated, but I'll take you through only the most important ones. We look at the severity of tricuspid regurgitation. The vena contracta was almost 1 centimeter. The right ventricular function needs to be good for a trach valve implantation. The TAPSE was good. The PA pressure needs to be reasonably okay, at least mild or normal PA pressures. It's only mild pulmonary hypertension in this particular patient. And then you need to look at the coaptation distance between the septal and the anterior leaflet. It's 1.1 centimeter, which precludes from having any a trach valve or clipping devices in this particular patient. So she's left only with a trach valve implantation. And finally, look at the inferior vena cava also. The inferior vena cava needs to be evaluated, because you need to have the tricuspid regurgitation coming well into the inferior vena cava. I think it's not moving. Yes, you need to have the tricuspid regurgitation jet coming into the inferior vena cava so that it can make the newly implanted valve work. So these are the parameters that you need to look at, and you also need to look at the distance between the hepatic venous inflow into the inferior vena cava and the IVC-RA junction. It needs to be at least around 2 centimeters for the patient to be acceptable for a trach valve implantation. You also need to have a cath study done. That was a cath study. The pulmonary artery pressure is mildly dilated 44. The right ventricular pressure is mildly dilated 44. The right atrium again 40. You could see that the inferior vena cava was 28/10. So the pressures inside the inferior vena cava also was significantly elevated. And you could also see in this tracing that the V wave in the right atrial tracing is around 40. You need to have at least more than 25 so that the TR jet would come and hit onto the newly implanted valves and make the valves work. So the RA pressures, the V wave should be at least more than 25. You also need to have a CT venogram done, like how we do for TAVI. You need to see the size of the superior vena cava, the size of the inferior vena cava, the length of the superior vena cava, the distance between the hepatic venous inflow till the right atria SVC junction. All these parameters could be evaluated with the help of CT venogram. The SVC was 2.5 centimeters here. The IVC was around 3.3 centimeters here, so we decided on appropriate size device. Again, 25 French sheath going through the femoral vein. The opposite femoral vein also needs to be punctured. You need to have 2 6 French sheath on opposite side. One for the catheter going into the superior vena cava, just to take minimal contrast injection during the implantation of the valve so that you don't cage the left subclavian venous flow into the superior vena cava. And secondly, you need to have another catheter going through the into the pulmonary artery to identify the position of the superior limb of the valve. So the first valve is being positioned. We make sure that the superior vena cava device doesn't close the flow from the opposite subclavian vein into the brachiocephalic vein into the superior vena cava. That was deployed, and then we need to position the inferior portion of the device in such a way that we don't cage the hepatic venous flow into the inferior vena cava, and that was again confirmed and it was deployed. Again, you could see that the contrast is being injected into the hepatic vein. Make sure that it's not caged. So that's how the device is implanted. Both the devices, the upper portion as well as the lower portion, has been deployed, and something interesting happened afterward. The superior vena cava and inferior vena cava pressures dropped immediately following deployment of the valve. But then the right atrial pressure, you could see that initially it was 35, it immediately went up to 60, primarily because you are blocking the reflex of the TR jet into the inferior and superior vena cava. The right atrial pressures immediately went up, and even the right ventricular pressures went up to 60. So that was something which was unexpected in this particular patient. And post-procedure, regarding follow-up of this particular patient, what happened was the procedure went on very well. It was just a 1 hour procedure. Following the procedure, the first thing that happened was, as she came out of the anesthesia, she had severe shoulder pain. We were not sure why she developed right shoulder pain, because ultimately we read and identified that it was because of phrenic nerve compression, which is managed by gabapentin. She had worsening of atrial fibrillation, tachycardia, which spontaneously settled down. She had RV dysfunction and RV dilatation. And it was managed with dobutamine. Her BP improved on the table. However, after 24 hours, she had drop in blood pressure because of RV dysfunction, which is managed with noradrenaline vasopressin. She had reduced urine output. Diuretic was given, and she had to be in the ICU for the next 3 days. She was sick in the ICU, but then at the end of 72 hours, she improved, and finally she was discharged. And that is a follow-up echocardiogram. And you could see that following 4 months, you could see that the trach valve in the inferior vena cava is working well. There is mild central jet. And also you could see that the right atrium, it started remodeling. That is on 4 months follow-up. That is the right atrial size is slightly smaller compared to the pre-procedure. So you have a positive remodeling. And now it's 1 year since the procedure has been done. She's doing reasonably well. No more admissions after that. Her creatinine is around 1.4, 1.5. No ascites, no more tapping, and she's doing good. The challenge is this particular the procedure as such, it's not very challenging, but then managing these patients following the procedure is going to be extremely important. So while admitting the patient, we always tell them once the procedure is done, they will be out of ICU in 24-48 hours. Probably that should not be conveyed, because most of them, I spoke to Dr. Ramdas also, they also had all these challenges managing these patients post-procedure in the initial 3-4 days. Thank you, sir.
Excellent case, Deepak. But I anticipated this because there is RV dysfunction pre-procedure also.
Yes, sir. We had a reasonable tap. See, the most important things for deciding on trach valve would be a reasonable RV function and a reasonably good PA pressures. It should not be high at all.
Yeah, PA pressure should be less than 50, and
yes,
taps should be more than 15, I think.
She was in AF. She's been having in AF for a long time.
Deepak, your the RI pressure increased to almost like
60.
From
60.
45
So
to 60.
that means probably the RV dysfunction is improving, because it become just like Epstein, the RV
Yes,
and RI. So your valve has displaced the both venous system.
True.
So you are improving.
True. The
Otherwise,
RI
no other
pressure has
explanation.
become equivalent to RV pressures.
Now that means 60 means even RV pressure has gone up.
So no, sir. To start
because
off.
RV dysfunction has happened, and probably it's improving.
So what happens is, to start off, the pressures inside the right ventricle, right atrium is 45, because it was well decompressed into superior and inferior vena cava. Once you close the superior and inferior vena cava, the right atrial pressures increase to 60, and which had to be accommodated in the right ventricle and pulmonary artery. So we need to have a reasonably working right ventricle and a pulmonary artery pressures, which is not very high, because all these pressures should be accommodated by RV and PA.
Yeah. So you'll have nightmares for the first few days.
First 3 days, it will be extremely difficult.
So Deva, what was the creatine fluctuation initially?
Creatine did not go up. Creatine immediately settled down. But initial 3-4 days, the output was less. With diuretic dobutamine, we were able to manage that.
Because many of the case, the cardiorenal syndrome, it is the back pressure making the extracellular pressure
renal
and
vein.
renal injury. Rather than forward, the backward is making the issue in the cardiorenal. So
You have to actually take care of the tricuspid drainage issue. Not hypertensive.
So primarily what we are... Yes, so primarily what you're trying to do is this particular patient, her renal dysfunction is like what Dr. Ashraf has mentioned, the increased renal pressures, renal venous pressures that leads on to renal dysfunction, and her hepatic cirrhosis led to ascites and multiple tapping for the ascites. So we are relieving the systemic symptoms so that they improve. The renal function improves, the liver function improves, ascitic, absolutely no ascites. And over a period of time, the right atrium, it starts remodeling. The TR, right atrial, right ventricular pressures, it all slowly improves over a period of time. So the TR it's severe TR because the RA and RV is almost similar. There is no cooptation. So the pressures inside the right atrium and right ventricle is almost similar. Compared to whatever size it was due prior to the procedure, the right atrium has started becoming smaller and smaller. There is no more ascites, no ascites at all. Creatinine is also improved. She symptomatically function class 1 to 2.
What was the post-deployment SVC, IVC pressures?
Sir, it immediately dropped from 28 to around 16.
SVC and IVC.
Both SVC and
Do you
IVC.
have a cath post in that 3 months post? Do you have a?
No, sir. 3 months. Both we don't have it.
And what happened to the cardiac output?
So the initial first day on the table, yes, sir, on the table, once the device was deployed, the arterial pressures it improved. The first day, her BP always used to be 90, but then in the first 24 hours, her blood pressure was 110, 120. But 24 hours later, once she started developing RV dysfunction, 24 hours later, the BP started dropping, output started dropping. So that time we had to manage her with diuretics, dobutamine, noradrenaline, and all those things. And slowly it could be weaned off.
I think we are.
So she's been in permanent atrial fibrillation. Not sure, sir.
Deepak, one comment. What is antiplatelet regimen for these sort of patients?
She's ideally to be kept on anticoagulants, warfarin, but then she had some GI bleed and all because presently she is on just clopidogrel alone.
And does the volume affect the sizing of the valve? Because it's right side, should it be hydrated for the CT or for Icck basically?
It's always you prefer 10% oversizing. You need to always get the maximum size when they are volume overloaded.
You see, what is interesting is in diastole, the valves open. So you have a diastolic equalization of RA, IVC, SVC. So I really don't understand how this pressure, significantly comes down.
The valve is opening only, allowing flow only towards the RA. It's not allowing flow back.
Yeah,
So
no, but
definitely
when
it has to be
valves open,
normal.
You have a diastolic equalization of all the pressures.
So during systole, the systemic pressures are significantly reduced. That is the principle, how it works. Systemic decongestion during systole. And during diastole, again, the flow comes into the atrium because of venous pressures.
Diastole it is open.
Yeah,
it's open.
So you have diastolic equalization.
That's the only thing. Cardiac output can come down because the flow from the SVC or IVC into the RA can come down because RA pressure is maybe equal to that. So that's why cardiac output is going to come down.
Yeah, so you should check the cardiac output and then only tell us be told about the pressures. The second point is that, it is a misconcept that, when there is RV dysfunction, the tricuspid regurgitation has an outlet for the RV. So in fact, when you actually close down the, reduce the TR, the RV actually tends to worsen. It will not improve.
Yes, sir.
So in fact, there are surgeons who don't really do a very tight...
True, sir. It's mandatory that for a patient to be accepted for a trach valve implantation, they need to have a reasonably good RV function. Thank you so much, sir. Thank
We'll go to the next case, device closure of aorta to LA fistula, Dr. Rajesh.
Good evening. After hearing all these Icck interventions, this is nothing, just a simple complication after a DVR. This is a 66-year-old patient who had a DVR using Chitra valve. She came later with progressive effort dyspnea, class 3, and severe fatigue. On examination, she was in atrial fibrillation. She had a pansystolic murmur, and this was the X-ray which showed LA enlargement. She was in AF. Investigation showed a little bit of hemolytic anemia. And I was surprised in the echo room that there was nothing. The gradients were normal, slightly increased, maybe because the patient has anemia due to hemolysis. Then there is no flow into the left atrium. See here also, nothing great seen. So we again examine the patient, and but the patient had a very loud pansystolic murmur. She had features of hemolysis, so no paravalvular leak seen, nothing. So anyway, we went ahead and did an T, which showed this unexpected finding, a continuous flow from the root of the aorta to the left atrium. So this is the picture. So what to do? First, I thought we'll leave the patient alone, but the patient had severe dyspnea, hemolytic anemia, and they requested to do something. Now, in medical college, everything will be unfit for anesthesia, you know. So very difficult to get anesthesia. I'm sorry for making this comment. We don't have a transesophageal echo inside the cath lab. We have only transthoracic echo. So endo means transesophageal echo guidance is not there. No intracardiac echo. So only fluoro guidance is there. So I thought somehow I will try. These are the angios. I don't know whether you can see. It is the entry from the very root of the aorta just into the LA. So we used various catheters to introduce a wire. I thought I will take a coronary wire first because the defect is not that large. So after repeated attempts, I could introduce a coronary wire into the LA. You can see that that coronary wire is moving towards the spine. So that was confirmed by transthoracic echo also. You could see a little bit images of this coronary wire inside this thing. Now, I could not push the catheter over this coronary wire. So what to do was the next question. So we took a small coronary balloon and it was protruding outside the catheter. Just while doing the BAT technique, it was inflated with 6 atmosphere pressure and then pushed it. Somehow it went inside like this and the position was confirmed. This is the relationship of the defect to the annulus. It is very, very close. And we took a ambulatory duct occluder to 6,610. You know the dimension. 6 is the middle waist diameter. The next 6 is the total length, and the 10 is the diameter of the disc. And that was deployed just by fluoro guidance and transthoracic guidance, and the device was released. So this is the device released, and after the angio, there is no significant. So this is the TE after the procedure. No significant leak. The discs were moving normally. The fluoro also was reassuring. So this aorta to left atrial fistula is not a very common thing. Very few cases are reported. It can be closed with a device. Actually, the first case was reported in a patient with aortic dissection. So there are multiple causes like bacterial endocarditis. It may be traumatic, congenitally iatrogenic. So after valve replacement, there are around 20 cases reported. 8 cases were managed by percutaneous approach. Maybe this is a 9th case, to the best of my knowledge. Surgical techniques like faulty suturing, aggressive decalcification, then manipulating the aortic valve after mitral valve implantation, all may be the cause. Unexplained heart failure is the cause, is the manifestation. Small fistulas, you can leave it alone, but hemolytic anemia is the danger. So even if it is small, it can cause nuisance and it can be close to the device. So the only message is the imaging of aorta to LA fistula may not be that straightforward. If you find a patient with a valve replacement and hemolytic anemia, you don't see any paravalvular leak, nothing in the transthoracic echo, always remember about this entity. Thank you. Yeah. I agree, sir, but what I heard was a pansystolic murmur.
Nice case, sir.
But whatever said
what was
and
your preference for ADO? How did you decide on the device? How did you decide on the device to be put?
Okay. Anyway, any device can be taken. So I am comfortable with this device because I have used this device for multiple procedures. I don't know. There is no in that 8 cases in the series. Many devices were taken. Some used just PDA device. Some used muscular VSD device. So at your convenience.
I think I should the all the fellows should note the relevance of clinical examination. I'm sure if in the absence of proper clinical evaluation or auscultation, this would not have been picked up because routine transthoracic echocardiography did not pick up. Most the GE machines tend to, I mean, that grayscale is there are software that improves the image, but at the same time the color is not as great as some of the older machines. So I think that's very important that clinical evaluation is done.
No, that's
Transesophageal, sir.
Great case, Rajesh. Great case, Rajesh. Basically, the question was the which device and all. But I think aorta to LA is not a much issue. But if it is aorta to RA gerboid defect, you can't make an oversized and specific device has to be there. So I think whatever your device chosen is good. You can use muscular or what ADO2 because the distance is only 6 or 7 millimeter. ADO2 will be 6, right?
Yeah.
Yeah.
Yeah, sometimes cath technicians also tell, you take that device, that will be better.
How did you manage?
What?
How did you manage to see that the device is plugging? You didn't use TE. You didn't use. How did you ensure that there is no leak while you're before releasing?
No murmur. That is a first. Hold on to your stethoscope. So strongly, however big interventionist you are. So you auscultate. The murmur is lost. Then anyway, we. Yes. Okay. So. So after the procedure, there is no murmur. Okay.
But it's very important to have a T. Even if you don't have it, you should push the machine from the OP and do it. It's very important.
The thing is, we have 4D echo machines, but no permission to take it into the cath lab. The HDS issues. They have kept it in 4 rooms, so we don't have permission.
You are the HOD, no?
Pardon? We have transthoracic machines, sir. In both the, yeah. We have the luxury of echo machines inside both cath labs, but no T probe.
Yeah,
We do only under fluoro and transthoracic guidance. Actually, we have to publish it. We have done more than 1,500 ASDs with only fluoro and transthoracic guidance.
Yeah.
Thank you,
sir.
Rajesh.
Thank you, sir. We'll go to the next case.
Let's go to the next case.
Dr. Jayesh.
Manoj Ravi. No, sorry. Jayesh Bhaskar.
Good evening. I'm grateful to the organizers for this opportunity. So there is no suspense here. The topic itself is self-revealing. Now, an 84-year-old male was referred with acute onset breathlessness and desaturation. So he presented to the ED, and the ED physician initially managed with NIV. They did an echo. They informed that it's apparently normal. The BNP was normal, TROPI negative, and suspecting an acute pulmonary embolism, they did a CT. CTP was no PE, some aortic root dilatation, but only 4.7 centimeter, and lung parenchyma was normal. So they provisionally made a diagnosis of respiratory failure and shifted to the medical ICU under the critical care, and patient was okay on nasal prongs. Next morning, while patient was having his feed, Kanyi, patient developed severe desaturation, and he nearly collapsed, and the intensivist there intubated. And next morning, while they were attempting an extubation, the junior intensivist noted that while making the patient sit up, he was developing desaturation, and on lying down, the saturation was improving. So that observation led to the provisional diagnosis of platypnea orthodoxia, suspicion of this. And we did a detailed echo next morning. While patient was intubated, we did a TE, and there was a PFO with significant right-left shunt. And we did a bubble contrast, and significant shunting was observed, right-left shunting was observed. So a provisional diagnosis of this was made. Platypnea orthodoxia syndrome was made. Now, this is a CT chest. Actually, this was the PE protocol. You can see the RA. This at the sinus of valsalva level. The aorta is quite large here, and higher up, the aorta is dilated up to the aortic arch. Actually, even the aortic arch was for 0.5 centimeter. We did a cardiac catheterization next day, and patient had normal RV and pulmonary artery pressures. RA-LA pressures were equal, and the pulmonary vein saturation was 99%, whereas there was a drop in the LA level up to 85. So this is a Greek word, platypnea, platis meaning flat, and pnea meaning breathing. So upright dyspnea with concomitant arterial desaturation makes the diagnosis, and it was initially described in the 70s in hepatopulmonary syndrome, and other anatomical subsets are only two subsets will predispose to this, either intracardiac shunts like ASD or PFO, and intrapulmonary shunts like pulmonary AV fistulae and hepatopulmonary syndrome. And wherever there is a ventilation perfusion mismatch and shunt. So probably how the patient develops desaturation while sitting up is probably the interatrial septum gets stretched during the upright position, leading to an increased shunt. And the interplay of all these factors leads to larger shunt and desaturation in the sitting position or upright position. So a clinical diagnosis has to be made with severe dyspnea or hypoxemia on changing to upright position, and failure of supplemental oxygen. Just like any right-left shunt, supplemental oxygen doesn't correct the hypoxemia. And TE with bubble contrast is quite diagnostic. But if you don't see any right-left shunt during in supine position, you can use a tiltable TE. That's said to be diagnostic if there is no right-left shunt demonstrated. Now, an oximetry value, at least 5% fall in oxygen saturation or 4% fall in arterial PO2 from recumbent to upright position is said to be diagnostic, but there is no consensus on that. So we went ahead and closed the PFO with a 25 millimeter PFO device. It was not a very complex PFO, so we went ahead and closed with 25 mm device. And post PFO closure on table within minutes, the saturation improved to 94%. And on day 2, patient was sitting up with and maintaining saturation. And by day 2, we could discharge the patient. He had come last week for a follow-up 4 months. Saturation is 95%, and he is doing quite well. The aortic aneurysm was left around. So take home is this platypnea orthodoxy syndrome is rare, but diagnosis can be made with a good clinical suspicion. Luckily for us, the junior intensivist made the diagnosis. And aortic root dilatation causing this syndrome is very rare. Only one case report I could see. Probably there were many more diagnoses, but only one report I could see. And correction of the shunt can relieve the hypoxia and symptoms. Thank you. No idea, sir. During COVID times, when they were monitoring the saturation, he's 84. They said there was some drop in.
Before when I was not there.
There was
Yes,
some.
yes, okay, okay.
Can I
Yes.
can I complete the answer,
yeah.
Ashraf?
Sure,
Sorry.
sure.
So there was some drop in saturation, and some pulmonologists advised them to take nasal oxygen at night and all. But there was no demonstrated POS earlier.
It is a great clinical observation by your intensivist to make this diagnosis. I think it's a relative contribution of the IVC and SVC flow. When you stand up, the IVC relative flow will be more, and that is more directed towards that PFO. That's causing the syndrome.
Probably the eustachian valve also plays a role in directing the blood to.
No, SVC will be low.
No,
It's more, IVC is more.
now somebody has done an upright T and said that it's the stretching of the IAs that produces the largest effect.
Just great case. Actually, in the age group, we have to exclude even the intrapulmonary shunting because you have the PFO demonstrates the bubble test. They have people graded. It is only less than 20% of the RA when compared to LA. So to make that desaturation, we had to exclude associated intrapulmonary defect. I mean, AV shunt is there, whether LFT or any other.
That also can be
cirrhosis.
seen. The bubble contrast will show that also.
No, no,
That's why the cath was done, Ashraf.
Yeah, no, that's
PV
right.
saturation is normal.
So,
Now, bubble
pulmonary
contrast will
vein,
show that.
intrasegmental pulmonary vein abnormality, anatomical variation do occur. So even if all pulmonary vein, no,
No,
not
even
all.
pulmonary fistula can be seen by the
Yeah,
bubble
so-
contrast. That was not seen. That it
But
is
it-
only
it's
through
checked
that
for-
PFO.
at the end of the
Next
5 seconds.
Next time I'll remember your words. I'll do that.
Okay. But they will get very
Thank
great
you.
scenes.
Only on that. Okay, shall we go to the next? PBL closure. Dr. Manoj Ravi.
No, it's the next case is by Dr. Rajesh. Device closure of LV
No,
to
Rajesh,
RA shunt.
Rajesh
Yeah.
once again.
Yeah.
That's why.
I don't think that these complications are induced by our surgeon because he is also Rajesh, he will beat me. Believe me, it was both these cases were gifted to me by some other hospital. This is a 52-year-old female mitral valve replacement in 2010. Actually, she was diagnosed to have LVRA shunt by us in 2015 itself and was advised surgery. But she was not willing. So one day she got admitted with a terminal heart failure, multi-system failure. Definitely unfit for GA, only skin and bones. So no TE, nothing, no imaging. So a cath showed a QP by QS of 2.14, RVSP 75. Sorry. This echo showing the acquired LVRA shunt after mitral valve replacement. So there are three types: type 1, type 2, type 3. I'm not going to through to the details of it, but I carefully see what is a distinct, what is the anatomy of that tract. Because it's of different types like elongated, sail-like, flap-like, fistula form, cystic, thin-walled, windsock type, etc. So during detailed echo, I found that it is a type 1, but and sort of a windsock type defect. This is a 3D. You can see the defect there and the shunt through it. So the indications for closure of an LVRA shunt as per Shakil Qureshi's heart failure, RV volume overload and pulmonary hypertension. My patient has all the three in florid forms. Now, surgery, the problem is the case series shows that the mortality rate is around 50%. So it's a high risk thing. So this surgery turned down case, patient not willing. So we discussed the option of device closure. In medical college, it is under insurance. So whenever things are free, they will agree. So the type of LVRA shunt is very important. I told you it has importance in deciding the management. Now, my apprehensions were risk of worsening of TR, complete heart block. Then, as you told, there is nothing, no GA, no TE, no eyes. I have only fluoro and a transfer as a guidance. No, but only the hope was around 13 cases of LVRA shunt device closure is reported in the world, and all the 13 cases were successful. So I am going to do the 14th case, but that I had issues, stress. So again, through going through his series, I found that the malalignment of device, secondary TR, cardiac conduction defects are the complication. So I anticipated it. And as for the latest series, 13 cases were successfully closed. The procedure is local anesthesia, sedation with a midazolam, eye prophylaxis, heparin was given. Technique cross from LV to RA. Now, how to deploy the device was the crucial workup inside my mind, whether to do it from RA side to LV side, as reported by one operator, or from LV side to RA side. This is the LV angio. You can see the location of the defect. So I used enough dye because I am going to depend purely on fluoro. So this anatomy will be registered to my mind because I'm almost completely dependent on fluoro. Then the next was sorry. Okay. Anyway, some slides are missing. So I went on trying to cross this defect with multiple guides, multiple hardwares, but it was ultimately a Lima guide which went through this defect. So that was exteriorized. And then over that stiff Termo, an ambulatory torque view delivery system was introduced. And again, an ADO2 device was used. Why I preferred this route is we have enough experience of closing RSOV from right side. So I thought I'll be comfortable because that manipulation is easier for me. So the ADO2 6412 was introduced. And actually, I anticipated that the entire system may jump back into the RA. So sorry. So it was actually deployed in the one discussed deployed in the aorta and then gradually withdrawn. And under fluoro and under various views, echo window was good. So the device was deployed, positioned, and you have to make sure that all the three parts of the device are deployed properly. So many times fluoro was taken. Now this is a Chitra valve, so the disc movements were analyzed properly. Then the echo was done repeatedly to see that there is no regurgitation. The gradients are all normal. Then we did the final LV angio. It is perfectly normal. That is absolutely, there is no leak. And the device was deployed. So this is a repeat transthoracic as well as transesophageal echo. There is nothing, no residual leak, nothing. So you cannot close this, you call this LVRA shunt as gerbot because this is an acquired LVRA shunt. It can happen after MVR, AVR, after VSD closures, endocarditis. It can be post-traumatic. It can be after an RC occlusion. It can follow after your endomyocardial biopsies. So very aggressive debridement below the non-coronary cusp can cause injury to the membranous septum, and trauma from excessive retraction during the surgeon's assistant can cause this. So during mitral valve replacement also this can result because when they try to remove the calcium from the posteromedial commissure, it can damage the membranous septum. So take home message is an acquired LVRA shunt after mitral valve or aortic valve replacement, though an extremely rare complication, can be safely managed by us because the surgery carries more than 50% mortality. So now after 13th case, now we have 14 successfully done case. Thank you.
I think very good description, sir. Your choice of device also is appropriate because it is a double disc symmetrical device. So you have the option of deploying it from either the LV side or from the RI side. But I'm not sure about vascular plug because it does not have sufficient anchor on either side, can slip. Because I was also concerned about the full system jumping out. Vascular plug does not have any anchor on any
But
side.
people have used that also. Possible goes. Oh.
Basically, it's just like, yeah, basically.
Yeah.
Basically, Rajesh, just like what Sir said, the perimembranous VST closure, you can even do instead of TE, the transthoracic is enough for this type of shunt. And second thing is depends on the type, as what he mentioned. For example, it's very close to the conduction system. If it is windsock, like you can even use the our PDA device also if it is tubular, like something there, because that will not compress the membranous septal part and conduction tissue disturbance.
Yeah, advice, the best is you take the device with which you are the
No,
most
depends
comfortable,
on,
you know.
so for example, depends on the, the shape of the defect.
Okay.
Because whatever, we had to follow the perimembranous type only. You had to, for the fellows part, your angle has to be the 50 or 60 and 20 cranial, LA 60, LA 50, 60 and cranial 20. And whatever follow perimembranous basic closure, you can make it this device closure in the gerbo defect, even though I have not done
Ashraf,
previously.
we are running short of time. Thank you, Rajesh, sir. We'll go to the next case, a case of PVL closure. Dr. Manoj Ravi.
Good evening. I'm presenting a case of mitral paravalvular leak closure. My patient is a 74-year-old gentleman. He had undergone a mitral replacement for a caudal rupture in 2017. It was fairly asymptomatic for initial few years. Since last 2 years, he was repeatedly admitted for heart failure. On examination, he had features of heart failure. He had a pansystolic murmur. He had an infected keloid on the surgical scar. ECG showed an atrial fibrillation with controlled ventricular rate. Echo showed a normally functioning prostatic valve and a normal systolic function. He had a large mitral paravalvular leak present laterally. It's a paravalvular leak laterally near the LA appendage. We tried to manage him medically, but despite optimum medical management, he remained symptomatic. We had to do something. So an indication for closure of a paravalvular leak is significant regurgitation along with symptoms of heart failure or hemolysis. Contraindication include systemic infection, mechanical instability of the valve, intracardiac thrombus, active ischemia, and short life expectancy. We had to decide upon whether we should go for a surgical closure or a percutaneous closure. The problem with surgical closure was the mortality rates are high when compared to the index procedure. The second problem was there can be a recurrence of the paravalvular leak even after the second surgery. And our patient had an infected keloid on the surgical scar, again a contraindication for redo surgery. So we planned for a percutaneous closure. Location of paravalvular leak is important in percutaneous closure. This is an anatomical view of the site of paravalvular mitral regurgitation. We had a lateral paravalvular leak near the LA appendage. This TE images. Sizing is again important because it will decide upon the choice of the device and the delivery system to be taken. 2D echo will give us some idea of the size by looking at the vena contracta. The exact size is decided upon by the 3D transthoracic or transesophageal echo. CT and MRI may be helpful in certain occasions. The vena contracta will give us some idea about the size of the device to be taken. This is a TE which showed device around 8 to 10 millimeter. Approach, you can go with a antegrade approach or a retrograde approach in cases of a mitral paravalvular leak. In case of aortic paravalvular leak, the most commonest approach is a retrograde approach going from ascending aorta to LV. Or in certain situations, you can go out with a transapical approach. So this is how we planned. We know the most important difficult thing was passing from LA to LV through the paravalvular leak. So punctured the septum as we do in a PTMC. Inserted the LA guide wire, dilated the septum. They introduced the Icck sheath. Icck sheath is a steerable introducer sheath. It comes in 3 different curves, which we used was a 22.4 millimeter curve. The advantage, it has a knob. If you turn the knob, you can turn the tip of the sheath in different directions. It also has a integrated hemostatic valve, decreasing the blood loss. So we introduced the agile sheath across the intraocular septum over the LA wire. Then we introduced a 5 French JR catheter over a thermo wire. Try to cross the cross through the leak to the LV. After multiple attempts, we could cross through the parallel leak to the LV, confirming that we are in the proper through the parallel leak. Here, we have to make sure that we are going through the parallel leak, not through the prosthetic valve lumen. 2 things will help us. One is the transesophageal echo. This is more important when you have a mechanical process without a radio-opaque disc like a TTK Chitra valve, or if you are having a biological process. So T is showing that the wire is going through the parallel leak. This is luckier than Rajesh sir. We had the 3D echo in our lab. The second important thing is fluoroscopy will give us some idea whether we are going through the parallel leak or the valve. If you look carefully, you can see that the catheter is reaching up to the rim of the valve in certain situations. In most of the time, we removed the wire, inserted a Ambler's excessive through the JR and parked in the LV. Removed the JR in the agile sheath. Introduced a 9 French delivery sheath through the wire and cross the leaf with the delivery system. We used an AVP3 device in this case because the leak appeared to be oval and concentric. This is AVP3 valvular plug. We devised the maximum size because it is coming around 10 millimeter. We used the 14 millimeter, 14 into 5 millimeter device. Deployed the distal end of the device. Pulled back, checking with a TE and a 3D transesophageal echo. That's a distal edge of the device. The device was deployed. This was the final position of the device. We checked with a TE. There was no residual leak at all. So device success is defined as no trivial or mild regurgitation. A moderate or severe regurgitation is termed as a procedure failure. Complications include valve interference, stroke, endocarditis, device erosion, and emergency cardiac surgery. Our patient improved symptomatically. Follow-up 2D echo showed no residual shunt. Even the gradients across the prosthetic mitral valve also decreased. This is follow-up TE showing no residual shunt.
Excellent case, Manoj. It's very important to have 3D TE before also, because we don't have an idea about the circumferential extent of the defect. There may be more than one. That's again, crossing the leak is difficult because you are going against the flow, because blood is coming and rushing into the opposite direction. So
the agile sheath will help you, sir. You can steer it.
Has made it
simple, more simple.
Simple. Okay. Thank you. Then.
Can you take a CT before the procedure?
No. We didn't.
Just one point. It's a very good case. In all these cases, if possible, put one more wire across, because if you have deployed the device and you come out and you find a significant leak, you'll never be able to cross it again. So always have a safety wire down while you're deploying the device.
Particularly if you need another device to you have a residual leak.
So always have one wire and then
Yeah. The last case. One more.
Dr. Hari Krishnan for his talk on device closure of atrial septal defects with marked malalignment.
Very good evening to all. I thank Icck for the opportunity. So I'll be presenting a device closure in ASDs with marked septal malalignment. What is septal malalignment? it is a significant risk factor for failure of ASD device closures. Here, the septum primum, if you go back, think about the embryology, septum primum is malaligned towards the left atrial side. If you go back, there are two things, septum primum first, followed by septum secundum. Septum primum actually closes off fully, and then there are multiple holes which develops in the septum primum, which is closed by the flap of the septum secundum. So that is how interatrial septum is formed. So here the septum primum is malaligned towards the left atrial side, as you can see in this picture, and there is a significant separation of the septum primum and the septum secundum. This is difficult to recognize with transthoracic echocardiography, and it is typically visualized in the mid-esophageal TE 45 to 90 degree sector. There's limited literature available on how to manage these cases. So this is the case, 8-year-old girl with incidentally detected murmur, 12 millimeter ASD by transthoracic echo. We did a TE which showed marked malalignment with ASD measuring 17 into 15 millimeter. So you can see the pictures. This is TE 0 degree view, which shows this is the RUPV rim, and when you see 0 degree, the ASD is visualized best when the aorta is already seen. So that's one of the important clues to recognize that there is malalignment. Usually in a 0 degree typical, it will be a 4-chamber view where you see the mitral rim. Here you'll see the ASD best or the largest size when the aorta is already seen. So going to the 45 degree view, so this is aorta, and this is the posterior rim. So you can see that normally when you see a TE 45 degree in an ASD, even if the aortic rim is not there, you typically expect this rim to go and attach here. So this is the ASD plane. But here you can see that there's another plane which goes more towards the right pulmonary artery. So here the right pulmonary artery will open up. So there is significant, this is how we recognize malalignment. So in 0 degree, 45 degree, and again in 90 degree, the typical 90 degree view, you see SVC, IVC and the atrial septum with the defect. Here, when you open up the aorta, only then the ASD is seen. And in a typical SVC, IVC view, you don't see the ASD. So why is it important to recognize? Because you can see these two measurements are different. So if you measure this, it is most likely that it will be a lower measurement compared to this measurement. So when you typically measure your ASD and plan your device sizing, I usually tend to go +2, but here you'll have to go +4 or +6 to cover that extra millimeters. So how do we the planning was to do TE, a standard ASD deployment technique, upsized by around 4 millimeters. So 17 into 15 we measured, plan was to put a 20 millimeter device. So it is important, I'll show you in the subsequent pictures, to splay across the rims, both the septum primum and the septum secundum has to be covered, but it shouldn't be wedged between any of these. So these are the pictures after deployment. Again, by TE, you can see this, this is a 90 degree view where one of the rims is across the aorta and the other rim, you can see it goes far into the gutter between the aorta and the right pulmonary artery. This is a typical 45 degree view which shows well splayed device. So going through the archives, this was a 33-year-old lady. So this also is a typical example of a malaligned ASD, but here the device had embolized. So this was a 33-year-old lady with 20 mm ASD by transthoracic, malaligned interatrial septum with a 23 into 16 millimeter ASD. Device closure was done with a 26 mm ASD occluder, but the device embolized to LA. So here, again, going through the view, 0 degree, it is seen best with the aorta. And this is a 90 degree view. You can see this rim is going more into the right pulmonary artery or the gutter between aorta and the right pulmonary artery. And you can see the device deployed. The important thing to note here is in 45 degrees, it is relatively okay, it is splayed. But in 90 degree, you can see that there's an angle that this disc is making with the septum. So comparing both So what went wrong in this? You can see that in 90-degree view, this is the angle which the LA disc makes with that gutter compared to the angle that the successful device did. So it is important to recognize that the device plays across this RPA or the gutter between RPA and iota and the iota. So septum here to discuss about malaligned ASD, the defect surface of septum primum is different from the septum secundum as seen in this picture. So it is typically visualized in a 45 degrees view. This is a 3D reconstruction of the of another patient, not the same patient. So what are the clues to recognize 0 degrees ASD is visualized when plane of iota is seen? There's no ASD seen in typical bicable view. Absent aortic rim in most of these cases, and appearance of rims towards the RPA or the gutter between RPA and aorta. In 3D, the rims are seen in two different planes. So consequences, you'll have to oversize. There may be failure of intervention if you have not oversized or not recognized malalignment, embolization. Aortic injury has been reported with a malalignment, and it is usually a bulky device, as you can see in this picture. What are the take-home messages? It is important to recognize septal malalignment. The TE 45 to 90 degree sector is important for visualization. It is good to appropriately size upsize the device size based on the ASD diameter at the septum primum, that is towards the LA, to prevent embolizations. And the device must enclose both septum primum and septum secundum without either disc being wedged. And the splaying is best seen across the anterosuperior rim on TE 90 and 120 degree views. And we have to think whether we need dedicated devices for spiral septum. Thank you.
Thank you, Harry. The septal malalignment can be identified on transthoracic echo also, particularly from the subxiphoid view. It is very well visualized in children, more difficult in adults. In the subxiphoid or subcostal view, we can see the septum coming, instead of coming vertically down, it will deflect slightly towards the left. That is an indicator. Whenever you have that, you do a transesophageal echo, and on 3D TE, we'll see a sharp edge on the anterior and inferior and superior. But when you go posterior area, you will see a flat surface. You will not see the sharp area where it can catch. So that will continue with the aortic area. So it will be a big plane. So you will have to oversize so that the device edges of the one edge of the device should splay very widely. And after device deployment, it will look little weird on the TE, but if it is identified, can it be closed properly?
As sir said, in 45 degree TE is like a short axis view. So
With this, I think if there are no more questions, we'll wind up the session. Thank you all the presenters.
Thank you, one and all. So we are done with today's session.
Of last year, 2022. Number of centers performing intervention has gone up steadily, and now, according to last year data, it is 148 centers are there in Kerala doing intervention procedures. And we have number of intervention cardiologists also registered, the Icck also gone up. Now we at present 344. After I became secretary, almost 45 new members have joined. And hospital with more than one lab, north we have 9, central 8, and south 5. And total cath labs zonal wise, north zone 54, central zone 58, and south zone 36. And coming to PCI growth in Kerala, actually it was a steady growth. But 2000 last year, actually I got criticism from the Pratap sir that because last time I didn't get too correct data. But this year, how managed to get the maximum number of data? Almost from the 99 centers I collected the data, and total number of PCI was
And coming to access, it is radial is going up. In 2021, it was 66% femoral and only 34% radial. But 2022, it is radial is 56% and femoral is 43%. And age-wise, in the younger, less than 40, around 3,600 patients. 40 to 70 age range is the maximum number of patients having coronary artery disease. Vessels treated, again, there is, you have to note that there is, again, single vessel disease more, but multi-vessel disease around 10,000 patients. And LM intervention, LM patients having LM is also, there is, numbers are increasing. Coming to bifurcation lesion, approximately 12% of the patients were had bifurcation PCI. 10% were CTO PCI out of that total number. And in the out of CTO intervention, 4,600 patient antegrade and only 37 patient had undergone retrograde PCI. And accessory device actually is a rotablator. It is around 530 cases. And out of this last year, RotaPro in 12, it is a new entry. OCT 895. IVAS is more than OCT. It is 1,074. FFR has gone down. It is a 458. IVL has tremendously, number has increased, 176. Laser, we have only one center, Dr. Deepak's Caritas, they have the one center, they have the laser, and they have done 25 cases. And OPN, number of OPN cases, 117. And in out of this peripheral IVL, four cases of peripheral IVL they have done. And complication is, it's very less, and thrombos is, according to the data I have collected, it is 0.2%, and mortality is around 0.36%. And primary PCI, it is around 33%, and total cases 115,000. Again, approximately 1/3 of the cases are primary PCI. And stent use, again, it is more DES. It is BMH is going out of shelf, and I think we are lucky enough to have seen so many BMS. But now our fellows and all, they are not seeing the BMS. Because BMS is actually it has come down. Vessel distribution in primary PCI, LMC is 442 patients, LAD is most common, then RCA followed by LCX, and Austral LAD in 1,600 patients. And valve interventions, balloon mitral valve 240 cases, aortic valvotomy 73 cases, pulmonary 174 cases, tricuspid valvotomy 24 cases, and TAVI, this is a TAVI number, it's a TAVI and TMVR. TAVI steadily increasing, and for the last 2022, there are 111 cases of TAVI has been done. And again, MyVal is 85, Evolute Medtronics 20 cases, Hydra 5, and Edwards Sapiens 1. And coming to valve-in-valve, the TMVR, mitral valve-in-valve, it is a 5 cases, all MyVal, and 1 pulmonary case of pulmonary valve intervention. Peripheral vascular interventions, iliac 1,034 cases, femoral populated 866 patients, carotid 276, and renal 42. Congenital heart disease, AST device closure 842, VST 294 cases, and PDA 332 cases, and 56 coil intervention using coils. And number of procedures, still it is government institution, Pariyaram is leading, is around 4,552 patients, and it's followed by Trivandrum Medical College. And come to conclusion, number of centers and number of intervention cardiologists are increasing steadily. Total number of coronary interventions have increased, and due to steady increase in both elective as well as primary procedures. Use of DES is almost 100% is use of DES, both in primary always as well as elective procedures. And BMS is in end of life. In pacemaker, average end of BMS is almost end of life. You have to change the battery now. Primary PCI is DES is always preferred. Radial route is more common than femoral route nowadays. Nowadays, all fellows, everybody, all junior colleagues prefer radial route rather than femoral. And the number of structural intervention except TAVI is remains static. But TAVI study is increasing, almost 111 cases last year. TMVR is new child in the block. Next year it will become boy, and after 3-4 years it will grown up and will have more just like TAVI. And use of accessory devices are definitely increasing, like rotablator, OPN balloon, even laser has started in our state. So it is increasing. Thank you. Thanks to all centers for sending the data. This time I'm lucky enough to get the more data. Anish for compiling the data, Merrill team, Abert team, and Viva scientific team for collecting the data. And thank you all.
Thank you so much. So with this, we are winding up today's program.